So thank you for being here this morning and to the Houston Heart Failure Management Conference. It's the third annual event, and we're very excited for all of you to take the time and be here. I want to welcome all of you for today's event, and I also want to welcome Dr. Bill Zogby, who's our chair of the Cardiovascular Division, who's here to welcome you all to the hospital and the conference center here. Dr. Zogby.
Well, good morning, everyone. Good morning. This is a good morning. You know, number one, I think you are an amazing audience for people to take of their time on Saturday. I know the weather is not the greatest outside, so I think it's good, keeps people inside. But to take time and learn a little bit about, heart failure. Now I know we've talked in the past about changing maybe the name of heart failure to maybe heart weakness or anything like this, and I think from an individual perspective, this is some weakness of the heart that has afflicted many Americans, including some of you who are here interested, or some of your loved ones and some of your friends. And this is a conference that we take pride in. Not too many institutions put together something for individuals who are not health professionals, if you will, but to learn more about this disease and how to live with it if you're afflicted with it, and how to prevent it, hopefully also, because this is also a preventable disease. And I think this is very important to engage between individuals and the health professionals, because I really think a most informed individual, a most informed patient is the one that would do the best and also work in a collaborative relationship with their healthcare provider, physician, nurse practitioner, whoever is touching your lives. And we take pride in this, and I'm so glad you're here. So I thought, besides just welcoming you, is to give you a feel of what we're trying to do here, to put it in perspective, because Dr. Bimraj and his colleagues have done an amazing job putting this symposium or course together. I think we're fortunate to be living, and many of you are from Houston, but I know some of you are also from outside Houston per se, to be able to live in a city where we have really the best of medical care that we can provide. And this is the Texas Medical Center, an aerial view. It is indeed the largest in the world of a conglomerate of healthcare facilities and physicians and healthcare professionals that we take pride of. Yes, we compete, but let me tell you, we collaborate a lot also on patient care. And I think that's very important. Collaborate not only on managing patient care, but also on the research portion, which I hope many of you will be the recipient of such innovations to try to improve their health overall. And this is our conglomerate within this Texas Medical Center. This is the Houston Methodist campus. On the left side there is the Research Institute. This is where you are. And on the right a little bit is the new tower, the new Walter Tower that is just adjacent to here, and I would welcome you if you have the chance to just tour around a little bit and take a look at this facility, because this facility just opened a few months ago, actually in September, and it's not completely full yet because we're still opening some of it's 22 stories, pretty much dedicated to heart and vascular and neurological diseases. And I think this is really an amazing investment in healthcare. We hope that you don't get admitted because this is an inpatient facility, but at least for you to know that indeed these facilities are available for you. Just God forbid that your situation gets worse or you need acute care, that you're there. And you need to really at some point in time to just pass by this Bush atrium, dedicated to President Bush and Barbara Bush, where if you're from Houston, you've probably seen this mural before on the first Methodist hospital, the old facility. It was on Fannin itself, and it was hiding behind all the trees and canopies and everything else. And Methodist Hospital Board, chair of the board, actually thought that this should be relocated somewhere so you could see that, because this was commissioned in 1963. 1.6 million little mosaic put together to do that, and actually very proud that it got an award a few months ago from the Restorative Society of Houston. And I think this is really a vision looking in the past and looking in the future as to what healthcare is about, which is predominantly taking care of individuals who need the healthcare, of those who become patients to take care of them. And I think it has the latest facilities of everything else. So it has truly, at this stage of the game, the state of art of care, of acute care of any facility. 360 beds, 14 cath labs, hybrid rooms with ORs, et cetera, and really a state-of-the-art facility. This year, you may or may not know, and you'll see that, is we're celebrating at Houston Methodist our 100th anniversary. Houston Methodist was actually downtown, and with the relocation of the Texas Medical Center, the first building, and I've been here personally in Houston almost 40 years. Next year will be 40 years. I trained here, I stayed here, and it is an amazing place to engage and take care of our patients. And, an amazing facility where, for my heart and vascular, we're ranked 14th in the country among 800 plus hospitals, and number 1 in Texas for the past 7 years or so. I wanted to share this slide with you because, yes, you care about heart failure or heart weakness or whatever it is, but it is an integrative approach because many of the heart failure patients need other things. They may have coronary disease, they may have valvular heart disease, they may have other things, pulmonary hypertension, and you're going to be exposed to some of these entities today to try to understand what really goes on in this heart. So we handle prevention and wellness, which I feel very strongly about. Heart failure and coronary disease can be prevented. Not all the time, but quite a bit of the time. Imaging is very important. Interventional, having the specialist who try to help the situation, intervene on valvular heart disease, obviously heart failure transplantation, and basic sciences. And you're going to hear from Dr. Cook today about the advances in heart failure research and how does that. And we feel strongly about education. This is a forum where we feel strongly about education to the public, but also we feel very strongly about educating the next generation of physicians and trainees because they are the future. And we want to make sure that we keep that legacy, we keep the best of care given to future patients. If you have heart failure, you're not alone. The projections for 2030 is more than 8 million people will be afflicted with heart failure in this country. And yes, with an aging population, you have more heart failure symptoms. The heart may still eject well, but it doesn't relax well. It's very interesting. This pump that is so precious to our well-being, needs to pump well and also relax well. So as we get older, it doesn't relax as well. And I think these are areas that are ripe for research. Obviously, there are other comorbidities, other illnesses that come as we grow older. And I think these are very important to make sure that the risk factors, including diabetes, hypertension, cholesterol, all the other things, salt intake, how do you live with heart failure? I think all these are very important. And certainly, if somebody has a heart attack or called myocardial infarction or MI, how do you improve the situations with acute care? So I think these are very important. This is a scientific slide, but I will translate it to you, okay? And there are stages in heart failure, meaning that one on the left side, stage A, no symptoms whatsoever, okay, just risk factors, all the way to the right where it is really advanced and you don't belong there. Advanced meaning you can't almost do a thing, you're bedridden, a lot of shortness of breath, and you're a candidate maybe for heart failure, heart transplantation, or an assist device. Most of you, or at least your loved ones, may live somewhere in A and B or have mild symptoms, but these are somewhat interchangeable. It's not completely progressive into this situation, and I think under good care and with good medications and knowing how to live well with heart failure, you see an arrow given to the left side to try to improve it. and maybe get you without symptoms. And I think this is the important thing, hopefully, that you'll get from this conference today with the leadership of Dr. Bimraj. And I wanted to end with saying thanks to all our faculty that are involved in heart failure. That's what they've specialized in after going into medicine and cardiology and advanced heart failure, and having all this training to try to help you, help the situation improve. If you have heart failure, prevent it, have a dialogue with them. And certainly they're not alone. Many physicians are involved with this, but also besides the physicians is the healthcare team. The nurses, the nurse practitioners, the medical assistants, all of them actually touch your lives one way or another. And I think an integrated team is probably the most successful in keeping you healthy and living with heart failure. And with that, I thank you very much for attending today, for being involved and engaged in this symposium that is tailored for you. Think about it as your forum to ask questions, to engage with these healthcare professionals. And I wish you the best in your journey today, and best of luck to you and to your health. Thank you very much.
Thank you, Dr. Zogby. I did not spend too much time speaking about Dr. Zogby's accolades because it would take a whole day. But he's, just a couple things. He's been a phenomenal division chair pushing the mission of a comprehensive, forward-thinking institution, and we're very grateful for that. He was the president of the American College of Cardiology. He was one of the few who carried the Olympic torch representing the United States in London, and we're very honored for his support and his vision that we all carry forward. So moving on through the day, I want to take a few minutes to lay the stage of why we are here. You all are here because either you or someone you care for, which means either directly or indirectly you've been impacted by this disease state of heart failure. We all are here because we believe it's not easy to do what you do. We believe that the success in trying to treat this condition is not in how medical care was built historically, because it's a chronic disease. You live with it. You make friends with it. You don't fight it. You try to conquer it. And that's not how classical medicine and classic models of care have been built. And what does that mean? A typical doctor-patient relationship has been ingrained in an instructive fashion. When you come to the hospital, you get instructions. We're delivering care. We're asking you to take pills and do things. That is an instructive pattern. What we're aiming for is a collaborative pattern, because we are failing if we stick to an instructive pattern. What that means is there are no instructions, there are medical care plans. There's partnership, and it's not have you taken your pills, have you been able to execute your plan? And what are your barriers? We sometimes say, oh, you're not taking your pills, you're not complying to the plan. I can confess that when I had to take a bunch of cholesterol pills, I probably took 1 out of 100. It's not easy to take pills. I confess. So I understand. Well, my cholesterol got better, so that's another explanation. It's not easy to go and exercise as much as, because life happens, life moves on. And if you think about it, the classic study in cardiovascular medicine was done in doctors, because doctors are probably the worst patients, trying to run around, do things, and not comply. But we understand, and what that means is we cannot conquer or achieve success for a condition which is stuck with you for life by trying to treat it in a 15-minute encounter or a 30-minute encounter. And that's our hope, that we instill in you a team partnership with your physicians to take control of not just your health, but your health care. And it doesn't matter who you see. It doesn't matter if you're not at Methodist, if you're having your own cardiologist, your internist, because the ratio of specialists and subspecialists to care for a particular disease, especially for congestive heart failure, and Dr. Zogby showed our list of advanced heart failure physicians, there are not enough advanced heart failure specialists to be caring for all heart failure patients in the country. Dr. Zogby showed you the staggering results. But our mission as a community nationally, as a community of heart failure specialists, has been to create systems where all other physicians who are caring for the heart failure patients, including internists, including cardiologists, including patients and their family, can take up this responsibility, share it, so that you can break it down and conquer it effectively. Dr. Zogby showed this picture very clearly, and it's important for everybody to know that at this progression of the disease, there's always efforts to push it back. You can always move back until you really reach an end stage where you can't. And at every point, success comes on what you do and what everybody does. So through the day, what we want to talk about is a formula for success, how you should engage, and I'm not going to belabor the details because you'll have a lot of opportunity through the day on understanding heart failure and doing it together and trying to rise above heart failure. And these are all campaigns by AHA and other organizations that we're hoping to promote. There are various sources of information. I think sometimes it's too many sources of information, and trying to identify an appropriate resource is important, but asking questions to your physicians and coming to conferences like these and exploring resources is important. And knowing what living with heart failure means, the symptoms that you get and how you deal with it, and then knowing what is available, what are the relevant options that are available, medications, devices, procedures. It is very complicated to navigate this, and partnering and pushing the agenda and not giving up and kind of saying there's always room for second opinion. There's always room for more work to be comfortable with what you've been offered and trying to take control of it. We also recognize, and I'm sure all of you relate to this, that caregivers of individuals who are struggling with this disease actually have their own stresses. And this has been recognized. It's a large study that shows that we're caring for a patient. We're not caring for the caregiver, but the caregiver is caring for the patient. And if you don't support everybody, the whole system fails. So there's opportunities to focus on this aspect. And we at Methodist have started a heart failure support group. And this is the information, and you have flyers outside. In fact, it was spearheaded from conferences like this a couple of years ago, and one of my patients, who is a physical therapist, you'll probably meet him later, I don't think Wayne's here yet, he is the point person, and he has put this together. They meet at the St. Paul's Church right around the corner, and this is a list of topics that he has put together through this year. Things like, aspects of how to cook with low-sodium diet and certain topics that we'll cover today. But the flyers outside, please pick it up, and then if you have an interest and time, contact Wayne, and his contact information is on the flyer. So the goal really is to be successful with living with heart dysfunction and take the failure out of heart failure. And we are desperate to change this term, because you can't have a success by defining something heart failure. The heart hasn't failed. So there's a national search on how to best define this condition, and if you have ideas, let me know. We'll have a raffle or something for it, and we can get you a prize. We come up with heart dysfunction, heart stress, a lot of things, but failure is a very give-up term, which is not what we want. So take control of your heart, your health, most importantly, your care. And that's what is a formula for success, and that's what we want you to walk out of today's conference. So you have the agenda with you, but I quickly want to point out that through the morning, we have a short discussions and lectures by experts in various aspects of what we thought were relevant to discuss here. We will have a cooking demonstration in the afternoon, which we've had the pleasure of having one of the local chefs that I'll show. Followed by the cooking demonstration, we'll have lunch. Through the lunch, halfway through the lunch, there's a caregiver support group, which is if you're caring for a loved one, you are welcome to go to it. It's not mandatory, but it's on the 5th floor, and they'll guide you up there to have a discussion what it means to be a caregiver for somebody with heart failure. And then that will be followed by 4 small group sessions where you will be broken down into groups where you rotate through these areas, where you'll have an opportunity to sit and have a focused discussion, and in a small room have some interaction with the experts in that particular aspects. We also have a special treat today. One of my colleagues, Joe Galati, will be speaking later. He's an author of the book titled Eating Yourself Sick, and he will talk about healthy living and healthy eating in general, and also focus on congestive heart failure. And I told you about the chef who's going to be here this afternoon, Chef Robert Del Grande and Chef Elliot Kelly. They're the chefs at Cafe Annie, a restaurant in the Galleria. And he's a fascinating guy. He's a PhD in chemistry and has a very innovative perspective on cooking and how to live with it. And I talked about the discussions. And before we wrap up, in the similar mission of trying to engage all of our patients, we have put together a multidisciplinary effort and created a heart failure patient education booklet. And I'd like Dr. Zogby to come up and inaugurate this, and this will be the first, you'll be the first group to get this booklet to walk out with. So,
there we go. Well, thank you, congratulations.
So this is an effort by many multidisciplinary individuals, which means we had a group of physical therapists, we had a group of nutritionists, all of our nurses, our psychologists, and everybody has put a lot of effort into this booklet, and you will have a chance to pick this up outside during the break. It's by the DeBakey Heart Center booth, and take time and look through. It's comprehensive, and we hope we can refer to this in some of the small group activities this afternoon.
Arvind, let me take the opportunity, number one, to thank you for putting such a forum together for patients, for taking the leadership to put also some manual to help our patients and hopefully prevent also heart failure. So I really want to thank you on behalf of our department, but most importantly, on behalf of patients. Thank you very much.
Thank you. And I want to acknowledge Andrea Creamer, who's not here today, but she has been behind making this happen, because if they leave things to me, they'll never happen. It's about a 4 years effort, but she's just been able to put everything together. So I'd like to give a hand to Andrea.
Good morning, everyone. My name's Mariana. We want to welcome you all. I'm one of the project specialists over this event, and I just wanted to let everyone know today throughout the sessions, we do have an automatic reply system. If you take a moment to text 2019 HFMC, if you text it to the number 37607, you can submit your questions, and when we have the Q&A sessions or when we're setting up for the cooking demo, you can submit any questions you might have for the speakers or just for any of the experts today. So just make sure you text 2019 HFMC to 37607. Thank you. And then proceed.
Just a few more housekeeping things for all of you to keep in mind. There has been a pre-event quiz that was emailed to many of you. A lot of you have responded to it, but if you have not, kindly take a minute through the session before the end of the day to just answer a few of those questions. It's for us to kind of understand how else we can change our efforts and really put ourselves in your shoes. And I was telling Dr. Zogby an example. When we first started this conference, we took a survey of about 100 of our patients randomly to understand what their needs are, what they want. And what was a little bit revealing for us is none of you, I'm sure, I'm sure all of you relate to this. Nobody wanted the term patients in the conference title. And we don't stop to think about it. We're all human beings. We go by names. You don't want to be called a patient. You're not a patient. You're trying to live a life. So subtle things like these are what we're not used to. And that's the feedback that we need so that this partnership is a successful partnership. So that's the title of this conference essentially came from all of you saying we want this titled as Houston Heart Failure Management Conference. I had to add that subtitle so that doctors and physicians don't want to come to this because we want to focus on you all. So the subtitle says for patients and families. So please take a minute to answer those questions. During today's conference, you'll have time to visit our exhibitors outside and have the representative at the booth sign off on your passport. And if you visit every booth and receive the signatures, you can submit your passport for a chance to win a door prize. So you can get an exposure to everything. And we talked about the caregiver breakout session at 12:30. Keep that in mind. And then we'd like to acknowledge the following organizations for supporting this activity. Abbott, Close the Gap, Medtronics, and Myocarditis Foundation has been very supportive of this activity. We will move on. We're running a few minutes behind, and I want to introduce our next speaker, Dr. Imad Hussain. He's one of my colleague, friend, and partner who will talk to us about what happens in heart failure, what really happens to the heart. Imad.
Morning. Welcome once again to the Heart Failure Management Conference. So this talk, the first talk, is going to focus a little bit on the pathophysiology of heart failure, but at a very basic level, at a patient and caregiver level, so that's easy to understand. So the first thing is, if there's no audio, I'll go over this with you. This is a normal heart. What happens is, this is your left side of your heart. This is the right side of the heart. Now they're going to label this. Give me 1 second. So this is your left side of the heart. This is your right side of the heart. The used blood comes through the veins through the right side of the heart. It goes into the lungs where it gets oxygenated and then comes back to the left side of the heart. Down here is the main pumping chamber of the heart, the left ventricle. This pumps blood through the aorta to your body, which is rich in oxygen. So this is a normal heart, how it functions. So it has 4 chambers. Maybe we can play it again. It has 4 chambers. This is the main pumping chamber, the left ventricle. This is the right ventricle. This is the left atrium, and this is the right atrium. Okay? So normal heart. Can we go back 1 slide? So what happens in heart failure now? Can you play this slide, please? So I showed you what the normal heart looks like. So say you have an insult to your heart, like a heart attack, or you get an infection which attacks your heart, something we call myocarditis. What happens is that your heart function is, as you can see here, it's much weaker than the initial image that I show you, the initial animation. So not enough blood is pumping forward. When not enough blood is pumping forward to your body, you start having symptoms like exercise intolerance. You start getting short of breath. Same thing happens on the right side of the heart. You have blood, instead of moving forward towards the lung, starts backing up, and you start getting congestion. Congestion means fluid retention. Like, for example, you'll start swelling in your legs. You will start having abdominal distension or fullness in your belly. Like once you start eating food very early, you'll start feeling full. It's called early satiety. Those are all symptoms of congestion. So heart failure these days is actually, there are two main types of heart failure. The one on your right is systolic heart failure. That is the one you just saw in the animation, in which the heart muscle or the contraction of the heart muscle is weak. The pumping function of the heart is compromised. The other side, on the right side, is something you call diastolic heart failure. So I would like you to think about it like this. For example, if you were lifting a lot of dumbbells, over time your biceps, what happens to them? They become hypertrophied, they become stiff. Same thing that happens in this type of heart failure. Most common cause of this type of heart failure, or most common risk factor for this type of heart failure, is having high blood pressure for years. So if your heart is pumping against high blood pressure for years and years, what would happen to the heart? It would get thick and it would get stiff. So the pumping in this type of heart failure, diastolic heart failure, the pumping of the heart is preserved. As in, if you must have heard of the term ejection fraction, it's normal. It's the normal squeeze of the heart, but it doesn't relax, it's stiff. So in order for a heart to pump blood, it has to pump, but then it has to fill again. Then it has to pump, then it has to fill again. So the pumping function is preserved, whereas the relaxation or filling again to pump forward again is what is compromised. So just to let you know, in the population at large, this is about 50-50%. One would not think that stiff heart is a common cause of heart failure. In fact, it's 50% prevalence in the community. The only way you can distinguish this is if we did an ultrasound of your heart. But symptoms of both of these types of heart failure are very similar, as we will discuss. So I just said that there are two types of heart failure. One is the weakening of the heart muscle. The other is increased stiffness of the heart muscle. So this is just an animation showing you congestion. Basically, when blood backs up into the vessels, there is congestion. The fluid leaks out and can go into your soft tissue. You can manifest as lower extremity swelling. So what are the symptoms of heart failure? You can have extreme tiredness and fatigue. You could be short of breath with exertion. You could feel inside your chest a rapid or irregular heartbeat. Again, as we mentioned, if there's congestion, you'll have swelling in the ankles, feet, legs, abdomen, and neck. You could feel really weak. So what that means is you're walking, and all of a sudden you feel like your legs gave out. And it's nothing else, it's just your legs gave out, and then you had to stop. And then you can have rapid weight gain. All of a sudden you say, my pants are not fitting me anymore, whereas they were a few weeks ago. What's going on? So those are the type of symptoms that you can see in both the stiff heart type of heart failure, called diastolic heart failure, and systolic heart failure. So a little bit of the causes, and then I'm going to tell you a little bit about how to prevent them. But the major risk factors for heart failure by far is high blood pressure, and if you had a heart attack, in other words, if you had a blockage in your heart. Those are the two major risk factors for heart failure. But diabetes is a risk factor. If you have kidney problems, something we call chronic kidney disease, it's a risk factor. Infection, typically viral infection. You had a sore throat, a cough a few weeks ago, and then all of a sudden, a few weeks later, you started swelling up, you're short of breath, you're fatigued, you don't know what's going on. You thought that you think it's the lingering infection, and then you go and get checked out and you find out you have heart failure. It's in fact a virus that attacked your heart and caused heart failure. There is a new thing, and it's particularly common in females, is stress-induced cardiomyopathy. We don't exactly know. We have some theories as to why that happened, but this is typically common in females, and is sudden emotional stress can cause heart failure. This type of heart failure is usually reversible, but not always. And then heavy alcohol and with illicit drugs like cocaine and methamphetamines can cause heart failure. So this is kind of this depiction of the same thing that we just talked about. So let's talk about some things you can do, or your caregivers can do, or you can talk to your friends about that can help prevent heart failure, okay? So physical activity is protective against heart failure, all right? So aerobic activity, minimum of 30 minutes, at least 5 times a week. It could include jogging, doing the elliptical, or brisk walking on the treadmill. Not only aerobic activity, aerobic means cardiovascular, you should also do muscle strengthening activity. I've given an example down here that this is a very good exercise. If you guys want to do a plank for 5 minutes or whatever you can do it for, this really strengthens the core muscles, and it is also shown, actually, the muscle strengthening activities have shown to reduce your risk of not only heart failure, but cardiovascular disease in general. And the more vigorous your activity is, or the better, okay? So that's one. Dietary habits, very briefly, I know Dr. Galati will be talking about this, but eating fruits and vegetables, 4 servings per day is the recommended one. Moderate alcohol intake, no more than 1 drink per day as an average. It's different for men and women, but as an average. Particularly eating whole grain breakfast cereals, and eating fish, and even drinking a moderate amount. So what about coffee? So anything more than 3 cups of coffee per day it's ill-advised, but less than 3 cups of coffee, we don't know if it's beneficial, but it's not harmful. But whole grain breakfast cereals and eating fish, especially if you can eat fish like more than 2 times per week, it's actually, there's a study that shows that it's protective. Salt intake. So guys, this is the actual picture. This is exactly how much, this spoon, I'll give you the size of it, but this is the total amount of salt you can have in a given day. It's 2 to 3 grams. I know it looks big in here, but it's basically a teaspoon. You guys seen a teaspoon? So it's a teaspoon of salt is all that is recommended. Anything more than that you're consuming, and that is total. So that includes all meals and anything else that you're drinking. So this is the total amount of salt intake. Not only, if you follow this recommendation, less than 2 to 3 grams, not only does it help with blood pressure control, it reduces the risk of heart failure. So this is another very important thing, is to take control of salt in your diet. Tobacco consumption, it's a very strong risk factor for heart failure. This is a new trend, especially in the Middle East, but I don't know how much you guys are into this, but there are hookah lounges in Houston in particular, is actually even worse than smoking because of lack of a filter, and so hookah, smoking, chewing tobacco, it's all considered the same high risk for heart failure. It's a risk factor for heart failure. High blood pressure, ideally you want your blood pressure less than 120/80. This recommendation changes from time to time, and we don't really know at what critical number is heart failure really becomes a risk factor, but I just wanted to keep it simple for you, blood pressure less than 120/80. High cholesterol, definitely a risk factor, and diet and exercise reduces cholesterol levels. Diabetes is another risk factor we talked about, and actually lowering blood glucose and diet and exercise, and some of the diabetic medications can lower your risk of heart failure. Not all of them, but some of them. 2 comments and then I'll complete. A lot of times patients have heart failure, or you're a caregiver, and you find out that you don't know what the cause of heart failure is. It's not blockages, you really don't know what happened, okay? So now we're beginning to learn more and more that a lot of those you have genetic predisposition. So if you have a first-degree family member who has heart failure, especially at a young age, like in their 30s, 20s, 30s, 40s, then you should ask your doctor about getting screened, or your family to get screened for heart failure. And then there are now options for genetic testing. So please consult a doctor if you are in this realm that you have a family member who had heart failure at a young age, all right? And then last but not least, chemotherapy. This is a new and upcoming. So we typically didn't make that relationship, but now it's more and more clear that if you or a loved one or a family member or a friend is diagnosed with cancer and they're going to go on chemotherapy, more and more chemotherapeutic agents are coming out. There are novel chemotherapeutic agents that are coming out, and they have cardiotoxicity. In other words, I mean, they can be toxic to the heart muscle. So if you're going on chemotherapy, or a family member or friend is going on chemotherapy, you need to know exactly what that is, what you're getting, and ask if there are any cardiac side effects of that, and if you need a screening test like an echocardiogram. All right? And so with that, I thank you very much. I appreciate your attention.
As all of you are having questions, please make a note of it. You will have an opportunity to have a discussion in the small group sessions in the afternoon in a more intimate setting where you can spend more time about it. With no further ado, we'll move on to our next topic of discussion. I'd like to invite Heather Chung to talk about congestive heart failure and what coping skills of it, because it's not an easy disease to get slapped on. And Heather's the system director of psychiatric services and very passionate and very resourceful for all of our patients. Thank you very much for being here.
Hi, thanks for having me here. I think this is my second time to present with this group, so I appreciate it. My role for Methodist, I'm the system director for psychiatry, so I have the psych unit, and then anything psychiatry in our other 8 hospitals, I support those initiatives. How do you move forward? Oh, got it. All right, so it's interesting for me having the psych unit because we're seeing so many patients who are showing up with comorbidities, with their depression, congestive heart failure. We're chasing everything on the psych unit. So it's important to know that any illness can trigger feelings of depression. So that is something CMS now is requiring Methodists to do when patients are admitted, whether they're in a clinic, we're having to do depression screening. Between 25 to 33% of people with chronic illness experience some form of depression. And you can understand that. Just think of diabetes. My dad was diabetic. Just the process of watching your blood sugar, your congestive heart failure, either you go to the physician and you hear that your levels aren't any better, depression is a common feeling and it creeps up on you. Very silent to me, no different than blood pressure issues. They're very silent, and your stages of feeling blue, it all creeps up on you. Women, statistics are higher, and men 5 to 12%. So this is something now we're really mandated to pay close attention to. And of course, this correlates with the high risk for suicide that we're seeing. All right, so what do we use to screen for depression? In our hospital, we've opted to use the PHQ-9 as our scale. Our psychiatrists like the PHQ-9 because it gives us a multifactorial score of question number 9, which is what I have in blue, is our screen for suicide. So if a patient comes in and they answer question number 9 with a score of 3, that means they're also suicidal. The aggregate score is what also guides us to whether or not the patient is depressed. So we start paying attention to those who are moderate risk, and the physicians now are pretty much trained to offer support. So if you come into a Methodist emergency room, we do the PHQ-9 there, and we now have telepsychiatry in all 8 of our Methodist emergency room, where a psychiatrist can be a part of your treatment team immediately via telepsychiatry. We do have the 1 psych unit. We have 17 beds, and we're in the process of hiring additional psychiatrists to take us up to 24 beds that we can care for these patients. But we have partners across the city that we offer care. At the HMH campus, we have 2 psychiatrists that support our patients in the inpatient unit. So just to let you know, this is an illness that we're really paying closer attention to, because you can imagine if you're depressed and you're diabetic and you're too depressed to check your blood sugars, that disease is never going to be controlled. And we've seen that with a lot of our patients. If you don't get that depression under control, the rest of the disease is not going to follow. All right, so what are your typical symptoms that you see? The emotions. Sadness may creep up on you from anywhere, anxiety, some level of guilt, anger once you realize that it's a new diagnosis to you. And that's where sometimes the SI symptoms for suicidality shows up, the irritability. And then what's your thought process? Is it something that's chronic you're dealing with? Your self-criticism, your memory. We see that with, I've even seen a physician recently who is diagnosed with Alzheimer's. Imagine what that is for that brilliant individual who can have no recall. Being confused, thoughts of death, suicide, chronic fatigue, not being able to now do the activities that you were able to do with your congestive heart failure. And I'm gonna pay a lot of attention to sleep. I can tell you, before I went to the psych unit, sleep was irrelevant to me. I thought staying up till 1 a.m. was fun. Not anymore. Sleep is key. Go to bed, enjoy a good night's sleep. If I leave here and tell you nothing else, enjoy your sleep at night. So even for us on the psych unit, we count sleep hours. If I see a patient who is with me for over a week and they're not sleeping, my guide to them, if you don't sleep, you're not leaving us. So get good sleep. It's free. Weight gain, pay attention to that. Sometimes the meds that we give you lead to retention. So pay attention to your weight gain or loss. And if you feel yourself not motivated, even in our institution, in my department, we're all trained now on motivational interviewing, because we as healthcare providers, we love to tell you guys what to do, but we never take the time to hear change talk. Did you agree with me that this is what you're going to do? And I'm Jamaican, so culturally, if you are a dietitian and you want me to eat Western food, I may not go there with you. So we need to take the time to really preach to the patient, but then come back and really listen to change talk. Are they willing to do the things that we're asking them to do? So this is something we're learning in the Methodist culture, and I have a consultant that's diligently teaching all of us how to do motivational interviewing and engage in change talk with our patient and stop prescriptively dictating what should happen. And when you don't do it, we say you've relapsed or you're non-compliant. That's not the case. So we're doing more growth on that. And then patients who are withdrawn, that's a concern. If you're active with your church, continue to do that, because social interaction really does make a difference. If you're seeing your loved ones neglecting their responsibility, pay attention to that. And then the biggest one is, if I go to the store and I see people who don't look too good, I'm wondering what's going on with them. So personal hygiene really sends a message that something is wrong. All right, so what do? Coping, talk is excellent. People don't have to be a formal therapist to be able to listen to you. So find someone that you can trust, that you're gonna engage and talk with. But now there's so many apps with therapists that you can use to real time on your phone, get into change talk with them. Taking control of your condition. When you go to the doc, be motivated enough to say, I'm gonna go home, make a calendar the next 30 days, comply with what you've agreed to. And again, focus on the treatment plan. The prior speaker talked about activity. That's key. Dopamine levels increase as we're out there, we're exercising, and get involved. And the freest thing, again, beyond sleep is laughter. Find people you enjoy being around. Enjoy your life. I mean, it's here. One life we have to live. So I'm promoting this in Methodist. Music therapy is something we have. We have a donor who have donated dollars. I now have a music therapist. I should have loaded a picture on there. So on the psych unit now, we have a dome, and patients are allowed to create their own playlist. And we use therapy to guide them in what's an appropriate playlist for music, because it's free medicine. If you don't have Spotify, get it and help yourself to create your playlist. So we're promoting that. And final presentation, Methodists now have a outpatient psychiatric clinic. Dr. Weinstein is the chief. The number is there. If you want to see a psychiatrist, we now have a psychiatrist here that can support you in your journey of wellness. Copy that number down. He's wonderful. They're doing genetic testing. He will coordinate with you what diet you need to be on and help you on your journey to wellness. So I'm really promoting Dr. Weinstein Clinic. He's the chief of service for my department. So that's it for me. Thank you.
For chronic conditions like heart failure, it's very important to break the barriers of psychiatric illness. And I tell my patients, we have a taboo, and psychiatric illnesses or mental health is equally important, has a science behind it. It's not just about feeling down one day or not, there's a subtle balance. And I think, and I'm sure Heather will agree to it, going to a professional for help just doesn't mean that you should be slapped on medications, and that sometimes that's the fear. You have a right to refuse. And I always say, like any physician, for mental health illness, you have to strike a card. If you don't strike a card, go to another one. Trying to find the right fit and the right physician, especially for mental health illness, is quite important, and we have to break that barrier and seek help. Thank you very much, Heather, for your enlightening talk. Our next talk is essentially not an easy one, because she's going to try to convince you that you have to take your pills. I'd like to invite Achi May, who's our clinical pharmacist in our heart failure unit. She will talk about medications, what they do for your heart, and why you really need them, and why you should also take control of knowing about your medications. Thank you, May.
Good morning. Like he stated, my name is May, just May. Okay, so today I'm going to talk about why do you have to take your pills? Why is it important? Okay, so first, just a brief background about heart failure. So like Dr. Hussein talked about, heart failure means that it basically means that your heart is not pumping properly. That's all it means. Because of that, because you need the heart to pump blood to the rest of your body, your skin, your liver, your kidney. As a result, you have poor, what we call poor perfusion, it's a fancy word, to certain organs. Congestive heart failure basically factors in fluid. You have fluids in your legs, you have fluids in your lungs, and so forth. So this picture is similar to what Dr. Hussein talked about. So you have your normal heart, and you look at the heart failure. So if you can see the left side of the heart, but if you look at the left side of the heart, that's a little bit enlarged, and you look at the normal heart, it's not as enlarged. So that's the difference. Okay. So treatments. We don't just go straight to pills. I believe in lifestyle modification. So if you smoke, quit smoking. If you drink a lot of alcohol, limit. My personal belief is a limited alcohol. Caffeine, limit your caffeine intake, eat healthy, manage your stress, work very closely with your healthcare providers, and that's very important. So those clinic visits are highly important, okay? So, treatment of heart failure. So before we get into the drugs, why do we have to take them? Is there any benefits to the medication? So the first word that we're going to talk about, or phrase, is mortality benefit. It's a fancy word that you see when you hear about heart failure guideline. It's like a big Bible for heart failure. So when you hear mortality benefit, mortality basically means death, dying. That's what it means. So we're going to talk about, so medications that have mortality benefit essentially will decrease your risk of dying from heart failure. Nothing is 100%, but it decreases your risk of dying from heart failure. So there are different classes of medications. Some of these words are very fancy, but we're going to kind of try to go over them. So the first is angiotensin receptor blockers. You hear ACE inhibitor, my ACE inhibitor. You hear your nurse coordinator, your physician talk about that. So that's one class of medication. You have angiotensin receptor blockers, and the fancy acronym is ARB, okay? And then we have the angiotensin receptor nucleoside inhibitors. Those are the newer class of medication. So on there, what's the purpose of these medications? One, they decrease certain chemicals, such as angiotensin 2. They decrease blood pressure. A majority of your heart failure medications are blood pressure medicines, and which is the reason why one of the number one side effects that you have from them is dizziness, because it can really lower your blood pressure. It will slow the progression of heart failure, and it will improve blood flow. Mortality benefit to this class of medication? Yes. So why do we need to take our A's, our herbs? Because it can prevent you from dying from heart failure, okay? So the class of medications are divided on there, on the table to the right. ACE inhibitors, we have captopril, enalapril, lisinopril, quinopril, and ramipril. And these are some of the ACE inhibitors that have been proven to show that they can improve mortality. We have condensate, we have the ARBs that are listed on there. Some of these medicines, you guys can recognize them because you take them. And then we have Entresto. Everybody has seen the commercial on TV. Entresto is a newer medication that has shown a lot of mortality benefits to the medication. So, so that's that on ACE inhibitors and ARBs and so forth. So next is the beta blockers. You guys have heard beta blockers. Why do we need to take beta blockers? One, it will decrease heart rate. They work by decreasing blood pressure. They slow down the progression of heart failure. They will decrease the workload on your heart. Your heart is a machine that's working 24/7. So when it's failing, you need to decrease the workload on the heart. So these medications do that. It will prevent another heart attack. So if your heart failure is due to a heart attack, it will help prevent a secondary heart attack. Is there mortality benefit to beta blockers? Yes, there is. And what kind of beta blockers do we use in heart failure patients? Carvedilol, bisoprolol, metoprolol. And some of you know these medicines. Some know it by brand names. So I had the brand name to know. A lot of my patients would say, when I say Carvedilol and I say Coreg, and they didn't know what Coreg is. So that's why I have the brand and generic on there. Diuretics or water pill. So water pills, why do we need to take water pills? And I think a lot of people know the answer to that. Like we talked about in heart failure, there's fluid retention. So they'll help keep fluid from building up, remove excess fluid and sodium. Of course, the number one side effect is it will make you urinate, so try as much as possible. If you can, not taking it at night. If you're once a day dosing, not taking that at night because you're not going to sleep. And if you remember from the last speaker, you need your sleep. Mortality benefit? No, there's no mortality benefit to it, but it will help relieve the workload on the heart. So when you pull out that fluid, because that's a lot of pressure on the heart, it helps the heart. So indirectly, you can kind of sort of say there might be some mortality benefit in there. Aldosterone antagonists, spironolactone and eplerenone. You guys know those medications. So what do they do? So aldosterone antagonists are diuretics, but the difference is they spare potassium. So when you take your Lasix and your torsemide, it pulls potassium, it pulls magnesium, and that's why you have the cramps. These class of medication spare potassium. They block a hormone called aldosterone, and they prevent salt and water from building up in your body. It also, like I stated, it would prevent low potassium, or what we call hypokalemia. Is there a mortality benefit to this class of medication? Yes, there is. Dilators. So Bidil, Bidil or hydralazine isosobide. Why? What is the purpose of this class of medication? They relax the veins, arteries. They make it easier for the heart to pump, and it will improve blood flow to the heart. Mortality benefit to it? Yes, especially in African Americans, because we had a study that showed African Americans benefited a lot from this medicine. So non-African Americans also benefit from this medication. Digitalis or digoxin. Digoxin helps the heart beat a little stronger. It will help with heart rhythm. So sometimes if you have certain heart rhythm abnormalities, we use that medication. Mortality benefit to it? No, but we found in studies that it will help decrease hospitalization due to heart failure. And you might say, okay, decrease hospitalization. Well, we have studies showing that the more hospitalization you have when you have heart failure, the higher your mortality. So this medication kind of helps, prevent hospitalization. Other treatments that might go along with when you have heart failure. So we have oral therapies, the IF channel blockers. That's another new medication, Ivabradine or Calonor. A few of you might be on that medication. Blood thinners, especially people that have AFib or an arrhythmia, or had DVT or PE, there are certain blood thinners you'll be on, aspirin, clopidogrel, ticagrelor, and those medications, like especially if you had a heart attack in the past. Warfarin, so I'm sure a lot of you know about warfarin, blood thinner, apixaban or Eliquis, rivaroxaban or Xarelto, dabigatran or Pradaxar, and Daxaban or Cevessa. Cholesterol medication, a majority of our heart failure patients are on that. The statins, nicotinic acids, omega-3 fatty acids, Zidia, fibrinoic acids, or Tricor. Antiarrhythmics, again, a lot of heart failure patients end up with rhythm issues. Amiodarone is a popular one. Sotalol, dofetilide, beta blockers are also used because they help slow down the heart rate, and digoxin, kind of like we mentioned before. So to answer the question, why do I need to take my medicines? Why do I need to take my heart failure medication? One, to prevent the progression of heart failure, to prevent complications of heart failure, because there are complications that can happen due to heart failure. Arrhythmia, heart attacks, there's a whole list of things. Death can happen. To decrease your risk of death, mortality, like we talked about, from heart failure. To decrease the number of hospitalization that you have for heart failure, like we mentioned before, that decreasing your hospitalization indirectly kind of gives you a mortality benefit. And also to continue your normal living, such as, if you're involved in your church, playing with your grandkids, your kids, basically taking your medication kind of, helps with that. And one other thing I didn't list on here, I didn't talk about, is as much as possible, ask questions. Pharmacists are the most accessible healthcare professionals that are out there. So your local pharmacist, you can call them anytime. We have 24/7 pharmacies all over the country. You can call, ask questions, side effects, before you make decisions about not taking the medication. Be informed, ask questions, and then you can make proper decisions. Question? Thank you. Oh.
A key distinction to make, I think May gave an excellent overview of almost what I call as a cookbook medicine, because for congestive heart failure, we have a cookbook of all individuals with a weak heart, which is reduced ejection fraction. And Dr. Hussain distinguished between that reduced ejection fraction and preserved ejection fraction, which is a diastolic heart failure. Most of these medications are relevant to reduced ejection fraction. For preserved ejection fraction, there's really not much that we know to do except controlling blood pressure and diabetes. So the cocktail of medicines and the list of medicines that May talked about are mostly relevant to reduce ejection fraction. It's also important to recognize that's why we talk about know what the diagnosis is, because congestive heart failure is the most confusing term that you can have in medicine. Even internal medicine doctors struggle with it. Even cardiologists sometimes struggle with it because we have tainted it with so many terms. It's called heart failure, congestive heart failure, right-sided heart failure, reduced ejection fraction, normal ejection fraction, right heart failure, left heart failure, valvular disease, it goes on. All of them mean something similar but different. So if you go into the hospital, go to the ER, and you had some fluid on your lungs, and maybe they took some lungs out, you can get labeled with congestive heart failure. But that doesn't mean you truly have congestive heart failure. So it's important to pin down, why do I have congestive heart failure? Do I have a normal heart muscle function? Do I have a reduced heart muscle function? Do I have high blood pressure? If I make my blood pressure, normal is 120/80. If I make my blood pressure 200/120, I can put myself into heart failure because the heart can't pump. You will have the same symptoms. If somebody misses their dialysis, they're going to have congestive heart failure. So it's important to distinguish those. That's where if you take control, know why you're doing, what you're taking for what, the list of medicines, you will be able to question appropriately, but also get the right answers. And May pointed out that A lot of those medicines drop your blood pressure, but that's not why you take them if you have low ejection fraction. You take them because they help the heart heal. Sometimes the blood pressure gets in your way. And the most common error that I see is somebody somewhere does not know all your history and then tells you, why are you taking these blood pressure pills? You don't have high blood pressure. And then you decide to stop them and everything crashes. So what May talked about is if don't stop or your pills or change anything, but that doesn't mean you should accept it and feel bad. You should question it, ask, partner, negotiate, try to reduce the number of medications so you know why you're taking what, so unnecessary pills can be eliminated. You go into the hospital and come out, sometimes you get stuck with pills which might not be necessary for your lifelong. So again, knowing those list of medicines, identifying why you're not taking what is probably what you want to embrace with what May talked about. We'll move on to the next exciting talk. As I had introduced Dr. Joe Galati, Joe is a hepatologist, a liver doctor, GI specialist, does liver transplant, but he probably knows more than any of the cardiologists here about heart health. He's the author of a book, and he's promoting healthy living, and we're very honored to have Joe here. Joe, thank you.
Thank you. Before he walks off here, I just want to give a thank you. I know how passionate he is about working with, I don't want to say patients, but individuals that are challenged with heart issues. And I think just a round of applause for Dr. Dimraj. Now, I'm going to need his help for a second. So as was mentioned, I wrote a book and I brought two, but I'm not just going to give them away. So the first one will go to anybody that honestly has, and we'll be looking to see who raises their hand first, a fresh clove of garlic in their kitchen. There you go, that lady right there. Okay, that's number one. Second one, who has cooked Brussels sprouts within the last 7 days? Oh my gosh, I saw your hand go up first. Now you're not fibbing, are you? You really did. All right. Where's the controller? Which is green is okay. All right. Well, thanks very much for inviting me. I'm so happy to be here today. And the topic that I was given is eating right. And I put as a subtitle there, it's easier than you think. Now, when I went to bed last night, I had my slides all set, ready to be here. 6 o'clock this morning, I woke up and I said, no, there's something wrong. So I redid the entire presentation, just wanting to make sure that we were right. And so what really is sort of bothering me in a sense is when we talk about eating and nutrition and heart disease and even liver disease, it is, are we talking about how to eat? Or are we talking about what to eat? And I truly believe that it is two separate problems and it is two separate processes that you have to go through. So as was mentioned, I am a liver doctor, and just for the cardiologist this is where the liver is. It's in your right upper quadrant, and we handle all sorts of different types of liver disease, hepatitis due to the viruses or hepatitis due to the medications. But the one thing that is absolutely inundating our service is something called fatty liver or non-alcoholic fatty liver disease. And I believe that this is public health, public enemy number one, fatty liver disease. So the one thing, just to go off onto a little bit of science and medicine before we get started is, all of you should be familiar with the term metabolic syndrome. And so a syndrome is any condition that has a bunch of different little pieces to it. So with metabolic syndrome, you have type 2 diabetes, obesity, elevated cholesterol or triglycerides, you tend to have an underactive thyroid, high blood pressure, and of course, fatty liver. Now, the problem with metabolic syndrome, these are the patients that I see. So many times patients come through my door through metabolic syndrome and a fatty liver, but when we look at them, They have untreated high cholesterol. They've got poorly controlled diabetes or hypertension, or they're on the verge of heart failure, and then we have to take care of them from a liver standpoint, but then redirect them to cardiology. And so when you look at fatty liver, for me, it is the tip of the iceberg with regard to obesity. And when you look at all of these conditions, we all know somebody, maybe yourself, with these vast, wide-ranging conditions. This is the chronic disease that is cutting lives short, and it is costing billions upon billions of dollars. It's all, the core of it is obesity and all of these chronic diseases that we see here. And so really the elephant in the room is obesity. It is obesity that leads to some forms of heart failure, hypertension, diabetes. Diabetes leads to kidney disease. Kidney disease leads to all sorts of cardiovascular issues. And so as I listed there, the diabetes, heart disease, fatty liver, kidney failure, cancer, depression, it's all tied into obesity. Now this is a painting I saw last year when I was in Spain. And it was a small little museum, a very, very lovely little place. And as I was walking through, I saw this. The name of this painting is La Familia. And I believe that this is so telling, that you have a mother and her children at the table cooking fresh fruit. You have to look at yourselves to say, how I live, how you all live, can your family and your children and your siblings be in that picture of La Familia? This is my familia, okay? Now, I was looking at this carefully, and if you're careful, you're probably saying, well, Dr. Galati, 2 people have cigars in their hand. What kind of healthy living is that? And there's some cocktail, glasses. This was my father's birthday. Now, my father actually is in New York. He's 94. He is streaming in looking at this. So we'll say hello, Dad. But everything we did was all about the kitchen. I grew up in New York, typical New York Italian family. Everything was about cooking, and my earliest recollections of being alive was sitting at my kitchen table cutting garlic for my mother, probably 5 years old before I could cut my fingers off. So we have to get back to that. We have lost our ways. And so as mentioned, the book, Eating Yourself Sick, really is the culmination of not only growing up and what I experienced at home, but really what I see with my patients every single day. So I'm going to touch on how to eat. So let's start off going to the market. That's where we get our food to eat. And this is booby trap number 1. Going to the market is a hazard to your health. One of many hazards I will talk about. But you have to become disciplined to try your best to write a 7-day menu. Now, if you can only do 4, that's better than nothing. But you have to sit down and say, okay, what are we going to have for breakfast? Monday, Tuesday, Wednesday, Thursday, Friday. What about lunch? Am I taking lunch? Is it going to be a leftover? What is it? And then what about dinner? What about snacks? Okay? You don't neglect the snacks because most people, the extra calories they get, people are snacking and sipping themselves into obesity. It's the chips, it's the nuts, it's the this, Think about your snacks. What condiments do you need? Okay, so you don't want to be cooking something and say, oh man, I got no olive oil. I have no cilantro, I have whatever. So make sure you get everything you need. Think about nutritious snacks for the week and carry them around. There's something called a Ziploc bag. Fill it, stick it in your car, put it in your pocket. I walk around with my lab coat with, a Ziploc of almonds. All right? So you have to do it. Don't go to the market hungry. You've heard this. That is the biggest mistake. And the supermarkets are hoping you go hungry. Don't buy anything that is not on the list, period. You have to be disciplined, okay? If you did not write Doritos, don't buy them, all right? Now, your goal when you go in there, so you make your list, you write it down, look around the pantry, the refrigerator, the freezer, you've got all your stuff, and you're like, okay, I'm going to start the car and I'm going to drive there. You're going to park the car, look at your watch, and say, how quick can I get out of there? Because the supermarket psychology, and I'm not making this up, they are doing all they can to have you loiter in the grocery store because you're going to buy more stuff. The stuff you buy is most likely junk. That leads to high blood pressure, diabetes, obesity, etc. So get in and get out. Do not taste the samples. Those nice little old ladies that are standing there have this because these are hyper-flavored food. Nobody is standing there with a cut-up green pepper to say, you want a piece of green pepper? You want a piece of green pepper? How about an olive? Nothing. It's crap, okay? So it is hyper-flavored that you taste this, your brain explodes, you're like, where is this stuff? You know, and you just start to buy stuff. So don't taste the food and limit the number of visits to the grocery. You want to go once per week, unless you know that Thursday is the good fish delivery day and you go in just to get a piece of fish or something like that. Okay, you have to be good consumers. Now, in 1975, your average grocery store had about 9,000 products to buy. In 2008, so this is 10 years old, 47,000 products, okay? They haven't invented 60 kinds of beets, okay? This is all packaged, manufactured food, stripped of nutrients, which they want you to buy so that you keep coming here for your heart ailment or come see me for a liver problem. Do we really need 40 kinds of oatmeal? Right? How many different crackers do we need? Now, the other thing is health claims. This drives me nuts, all right? Now, whenever I talk or do anything, I always target Pop-Tarts, okay? They're bad for you. Have them once a year. Now, who here really believes that a Pop-Tart is a good source of fiber? All right? So, you know, you've read the paper, you've listened to the radio, and you say, yeah, you know, fiber is good. Dr. Bimraj probably told you, eat more fiber, it'll control your blood sugar, you'll have more bowel movements, and you won't be constipated. So you're going around, and you're like, whoa, good source of fiber. Let me get Pop-Tarts. All right, come on. Okay, who actually thinks that you buy Pop-Tarts for a good source of whole grains? Right? Up there, whole grains, star, there's a little stamp. Or better yet, they tease you with strawberries, right? Okay, fruit, good, strawberry, good, Pop-Tart, moronic. Okay, but this is what you see. Now, there's something called the end caps. Don't be fooled. So when you're going down the aisle and you make that wide left turn, you see end caps, okay? This is strategically placed on both ends of the aisle, and they are stocked with cheap, poor nutritious, low nutrition food. This is for the impulsive buyer. They have it perfectly lined up. You go there and you're like, whoa, Chips Ahoy. That's exactly what I need. If it's not on the list, don't buy it, don't be fooled. You've got to go. You know, people are going to go to the grocery today and they're going to go crazy. But every aisle has end caps. Every aisle has end caps. Don't fall for it. Don't do it. Okay, so one of the problems is we have really lost our way with the end of home cooking. That is a dead art, it's sad to say. Now, this is exactly what I hear. I'm too busy to cook at home. It's too hard. Okay, cooking is hard. We're surrounded by food options. You can't walk 5 feet without seeing some sort of restaurant, drop-in food. You know, you don't even have to get off your couch. You got Uber Eats now. Huh? You know, oh, do I have to go to the door? Now they're going to have like a pass key and just, you know, chew it for you. You know, people don't want to clean up. I mean, this is mind-blowing. I don't know how I don't either laugh or jump out a window. Patients will sit there and I'll talk to them. I'll say, look, you are obese. Your glucose is out of control. You're in heart failure. You may need a liver transplant. You have to, you know, eat, cook at home. It's like, oh, but the cleanup, you know, my God, what are you doing? I'm too stressed out. I'm too stressed out to cook. And it's only me. A lot of single people, either never married, they're young, they're divorced, they're single, they lost their spouse. It's just me. So that's they justify not cooking because it's only you, okay? Okay, so now the other thing about supermarkets, and you have to look for this, is, and the grocery stores are preying on you. They are preying on you. Mealtime made easy because they know you're stressed out. I don't want to clean up. It's too much work. It's too hard. So they're like, okay, we know this is what the people are doing. Let's just make it super easy. So you walk into a grocery store and there's all this pre-made garbage for you. So mealtime made easy, I say heart attack made easy. Okay? Now, this is a picture I took the other day of pre-made meals made easy. Now look at this. They're playing with you. They are jacking you around. Simply plant power. Again, they're like, you know, plant-based diet is good. Cream, spinach, and kale. That's another buzzword. Kale is good for you. 9 grams of protein, whatever that means. I should buy this. Well, one serving is 700 milligrams of sodium. Now, the only differ I would have here, and it's not a big one, in my world with liver disease, our sodium limit is 1,500 milligrams, a little bit lower than what was mentioned, around 2 grams or 3 grams, but 1,500 milligrams. So you are well on your way with one rotten serving of that pre-made stuff. I don't even know what it is. Then you get some pulled pork, 1,600 milligrams of sodium. You're done for the day, and it's not even good for you. Something called grocerants. Again, these are grocery stores that are like restaurants. They want you to eat there and spend more time. So a few of Galati rules. Low salt foods, 1,500 milligrams. If you just eat these foods, you will never have to worry about counting milligrams of sodium. Don't eat anything in a can, box, or bag. Don't eat out. This meal here, Red Lobster, big mistake. 7,000 milligrams of sodium. What I would say is bookmark this website, World's Healthiest Foods, whfoods.com. It's probably the best website to learn about vegetables, fruits, how to cook, recipes, etc. And as I like to say, you want to eat earth food and not man food. Earth food came from the ground or had a mother. The man food is everything else that's manufactured. Last thing, and I know I'm running a little late here. How to eat. You have to master cooking slowly. Take your time. You have to have the right kitchen stuff to be able to cook. Knives, cutting boards, 1 or 2 frying pans, saute pans, skillets, roasting pots, stock pots, all the little tiny gadgets you could get for your birthday now. Things like an Instapot are making it a lot easier. Maybe if you really want to get to the next level, a little food processor, a blender, or a Vitamix. Master a few vegetables at a time. Learn how to grill them, roast them, steam them, get a wok, stir fry them. Play with flavors and ingredients. Make it fun. Do you like garlic or onions or peppers mixed in with your vegetables? Mix and match, and you have to experiment and have fun. Try to cook without salt. It takes about 2 weeks for your taste buds to reset to do okay without salt. Once you do that and you start introducing salt again, you're going to be sickened by it. Find 3 to 5 ways to cook everything. 3, 4 different breakfasts and eggs and fruits and vegetables, seafood, protein, snacks. Slowly build your menu and recipe file, do it as a family, and understand why you are doing this for your health and wellness and the control of any underlying problems. So the takeaway message here, obesity is the root of all of these chronic health problems we're having, especially heart disease. Excess calories, too much fat, and the serving sizes are out of control. Eating out is a hazard to your health. Cook at home. Teach your kids, your grandkids, your spouses, your BFF how to cook together. Eat as a family. Eat earth food. Shun the man food. And eat a plant-based diet. This is, again, I try to practice what I preach every single day. I'm still having, handing down from my family. We're still having lots of people over the house. We're cooking as a group. And thank you.
Joe, thank you very much. Very enlightening even for me. I gotta go. I probably should stop going to the grocery store. But important things in life and living, food, physical activity, which are probably the least addressed in your visit to your doctor. And I think I would encourage you to use this opportunity to learn more and probably teach us as doctors so that we can also have a healthy life. Moving on to physical activity, we have the pleasure of Dr. Viviana Testard, who's our rehab doctor, physical medicine and rehabilitation, where she helps a lot of our patients who end up in the hospital, unfortunately, but recuperate them out and integrate them back into a normal life. And sometimes questions like, how much can I do? What should I do? Health maintenance, and when you're limited, we're grateful for her to be here, Dr. Testard. Thank you.
Thank you. Okay, so now it's my turn to convince you to have fun having a physical activity. So now you eat right, and now let's move. So as they mentioned, I work at the rehab unit, and we've been very blessed to be able to participate in the care of many of you, if you've been in my unit or not, and sometimes continuing the care after you leave the facility, hopefully never to come back to my unit. I always say that to my patients because it means well. It means that you're doing well. So we're going to talk about physical activity and exercise. And I'm going to do this very brief, try to put a lot of information together in a very little time. But as I say, hopefully convince you that exercising and being active is good, not just because you're hard, but because everything in life. So exercise, I would say, and as I say this, underutilized treatment option that we all have also many times for free, or if you want to spend more, that's your choice, but something that you can do every day and something that you can carry on life for life. So the benefits of exercise, as we all know, has been very well researched for many, many years. And an exercise program should include different things like aerobic activities, resistance activities, flexibility, and neuromotor training that is indispensable basically to maintain physical fitness. But we're going to try to kind of separate different things so we understand better. So what are the benefits? Big, long list of benefits as you see here. That many times are familiar for us, many times not, depending on how active you are. So cardiovascular and respiratory function is going to be improved. We're going to reduce the cardiovascular disease risk factors. We're going to decrease morbidity and mortality, something that we already talked about, depression and anxiety and some other mood disorders that can be also present when we have heart failure or any other chronic condition, that the fact that you are exercising can also help to improve. Reduce pain, improve cognitive function, enhance your physical function and independent living. And this is important because, as I say later in my presentation, many times we use many of these benefits as difficulties for me to exercise and do something about. Enhance my feelings of well-being and reduce the risk for falls in older individuals, which is very high in patients with congestive heart failure also because sometimes the balance and also the lack of motor control, just because the condition of the conditioning put them in a situation that is more prone for falls. So sometimes we admit them with a hip fracture, but not congestive heart failure. We also, with the activity and the physical activity benefits, of course, we're going to improve our performance of work, recreational, and sport activities. So in general, and as you see here, and we know, I mentioned before, the importance of exercising is very high, and how much is good for me. And I would say whatever you want to dedicate every day for exercising or be active is good for you. So there's no limitation. This is a general recommendation. We aim to at least have 150 minutes a week, which means 30 minutes every day of activity, of exercise, with a moderate intensive aerobic activity. But also, if you do as little as 10 minutes, 15 minutes a day, it's going to be good. So we have 24 hours. So how many minutes do you really need, or how many hours? Not a lot. So important to do. And this is interesting, that just came to my brain, that sometimes when the patients come to the unit, they don't used to have so much activity as we propose and we do in our unit. So the patients come and say, I'm not ready for this. Nobody told me I had to be exercising for 3 hours, because that's what you do when you come to rehab. And that's not what you do at home. But this is a formal activity, and many people don't used to be out of bed by 8 in the morning and get back at bed at 5. They've been kind of doing and being very, very, quote unquote, lazy or very tired or very fatigued, that they don't do too much at home. And when they come to the hospital, they've been in bed for a long time because they've been sick. They come to rehab, bang, it's a trauma. So the fact that you at least are active, not necessarily when you are just because recovering from a congestive heart failure admission, is very, very important. So how we prescribe exercising. And as you hear, prescription is because exercising is like medication. So we already talked about taking your medications. Eat right. Let's start moving now. So how we prescribe as a physicians, we have a team of people that can evaluate you and, of course, get a good history, understand what is going on, how active you are. It's very important to know that, because you cannot come up with outstanding recommendations without knowing how active you are and how much you really understand about what you have to do or what you would like to do. So physical therapy and personal trainers can help with that. And I mention that because sometimes having somebody that commit with you to be active is good if you don't feel like I want to do it by myself. Like, I don't cook because I'm living alone. I don't need to cook. Well, I don't need to exercise because I'm by myself. Find somebody that maybe motivates you to exercise. So let's talk about heart failure specifically. So nothing new of what we've been talking, known to lead to a poor health-related, and then the term, quality of life. And that's what we rehab physicians do a lot. Let's move, let's try to have a better quality of life. Regardless of the condition or the chronic condition that you can have a life that can be very enjoyable. So, and knowing that, as we know, the heart failure is the most common reason for hospitalizations in our elderly population. Here is just a picture of what all the things that can happen to your body when you are in congestive heart failure. So, talking about exercise and physical activity sounds simple, but getting to adhere to a program is very hard. Some people commit more to the medications and many times to the diet, but to the activity is very hard. So what I'm going to discuss is how we need to understand the situation of the person that is in heart failure, and it's not just as a person, but also as a family, as a social environment that is affecting the motivation or commitment to be active, because sometimes we don't do that when we talk to the patients. So what are the predictors that we see for the patient to really commit to an activity? So the person, if he's younger, and we have many patients that are getting more in congestive heart failure that in earlier ages, that correlates with more understanding of why it's important that you exercise and you are active versus a person that maybe start thinking about in a later age in life. So the fact that you are a man Usually they commit more to an activity than females. That's been studies about. The fact that you have a regular history of activity, that also facilitate the commitment or the motivation for these persons to get active and maybe commit to an exercise program. But you need to ask those questions. The fact that maybe you have a little more education to understand what's going on, so the low income, low education, and poor family support usually is correlated with less commitment to activity or less commitment to an exercise program. Being single or having an inactive partner also affect negatively on your commitment to be active or get in an exercise program. And of course, mood, as we all know, will also be a big factor for not being motivated or committed. So we talk about the barriers, and it's something that we try to identify. What is really happening in your life that doesn't allow you to participate or commit to an activity to just maybe go for a walk? So we talk about internal barriers and external barriers. So many times, I just don't have time. I'm afraid that I'm gonna walk and I'm gonna hurt my body. My knees hurt, I'm gonna get worse. I don't have the discipline to, I never had done that. So they're all internal barriers that the person can have, but if you don't ask those questions, it's gonna be very hard for them to, or for you to understand why they are not doing what you maybe are recommending. What other external barriers exist? So as I say, it's not just the person, but also the family support, the environment where they are living. So it's too hot in Houston, so I don't go to walk because it's too hot, which is true. So let's try to find a good time during the day that maybe you can go and exercise, or it's too cold, or the humidity is gonna make my hair funny. So different reasons. So you need to, again, explore all these barriers in order to facilitate and come up with maybe recommendations and easy solutions, because I find out, and it's not often, sometimes the patients that have this chronic condition, in my opinion, and I'm a brain injury specialist too, have a little bit of problem solving and analyzing the situation and trying to figure out what else you can do. And I don't know if it's a little bit also like a little chronic lack of oxygen with time that make them difficult to understand what's going on with things and understanding how I take my pills, why I have to do this, why I have to do that. So I don't know if it's a little also something there that if we don't identify, it's gonna be very hard to be successful for the patients to be participatory in what I am recommending. So what other motivation, then let's see if the patient motivated to do things. So we need to include the care providers, the family members, and try to encourage the person to, we can do this, let's try to do that. Because if you are not motivated, you're not gonna do anything. You're not gonna take your medications, you're not gonna eat well, you're not gonna do exercise. So chronic conditions usually, it's not just with heart failure, but in general, make your mood low, your motivation is low, so you don't really do too much. So, and that imply, of course, daily activity. So again, just mentioning again, why different factors that make the patients not to be really involved in their own care or in a physical activity, which is my subject. So as I mentioned before, older age, lower social, economical status, the lack of motivation and financial or medical concerns that the patient may have. So different symptoms and lack of energy is also associated with the lower adherence to activity. So how we can promote this physical activity? So it's essential that we understand the barriers and what are your motivations. What can motivate you to do? So as I mentioned, sometimes it's just finding the right person to exercise or to be active is important. Physical activity, so what it is, because many times we talk about you need to exercise. And people think, I need to go to the gym and pay, and then I had to find the hours, who's gonna drive me? It's not necessarily. This is an exercise program that I'm talking about versus being active. Being active at the house, being active maybe going up and down the stairs maybe once a day, just can be your exercise. Or just look around or walk around the block. that's a physical activity. Participate in things at the house, that's physical activity. But if we're gonna be a little bit more into, let's talk about exercise. How I go back? Exercise, which, as I say, is a subset of physical activity that you plan, that is structured and repetitive, and is gonna improve and progress because you're putting objectives and goals that are gonna happen every day or in a week or in a month, and you will see the change. So how we start exercising. So 3 main things that you can do. Flexibility exercises, as I mentioned, that can be yoga, can be tai chi, or any other activity that you wanna get involved on. Also, activities that you usually do before and after you do the real quote-unquote exercise that I'm gonna mention after this. And what are the benefits? Usually you prepare for the exercise. So you are stretching, like everybody can stretch right now because you're all sleeping. So, but just stretch, just warm up and motivate your muscles for the movement. And you're gonna prevent injuries, and, but it's not gonna affect too much your heart. So in that case, then we move for the next step of exercise, which is the real work to the heart. So the cardiovascular or cardio exercise. So as the little heart say, is any activity that you wanna do. You can have a brisk walk, you can jump the road, you can do biking, you can do any activity that basically is gonna do more demand or gonna submit your heart in a little bit more at demand, increasing your heart rate and making you sweat a little bit and maybe make you a little bit more short of breath. So that's the cardio exercise. And then we talk about the strength training. And working with weight is very good. It's also a cardiovascular exercise or cardiac exercise. And the big thing that this type of exercise gives you is making your muscles stronger, had also an effect on your bones, on osteoporosis. It's gonna control better your weight because you are building more muscle. So your fat kind of get replaced by muscle. So sometimes if you don't lose weight, that's okay. You're building that muscle. But I'm talking about here a program and an exercise that you commit to do in a repetitive way. So how we start, what phases of exercise we do, what we do. So we start with basic warm-up. And the warm-up usually lasts between 5 to 10 minutes. It depends on how much time you have to exercise. As I say, you can do as little as 10 minutes a day, maybe 30 minutes, or maybe 45. Depends on your body commitment. And basically, it's gonna help you to get ready to the activity. So you stretch your muscles, and it's gonna just kind of prepare your heart, your lungs, and everything for the movement. Include the stretching, range of motion of your joints, and just get ready. Usually it's a low intensity activity that you will be doing. Then you move to the real work, which is the conditioning part. And as I mentioned before, is the real work where your heart is gonna be submitted to a big effort, and you're burning calories and getting more benefits from this exercise when we're talking about directly heart failure. You don't have to sweat to death in order to get the effect. And I will mention what you have to look for, but basically you can do this exercise for 15, 20, 30 minutes. And the good thing is that you will see the effects and you will increase that timing because your body is gonna basically tolerate a little bit more because you are building on that. Obviously, the first day when you have not exercised at all for your life, you're not gonna do 20, 30 minutes. So that's the thing of understanding how you're gonna develop, what is the prescription for that exercise. So you need to work with your physician, you need to work with your trainer, or even with your partner if you have some idea of how to exercise to develop your program. Then we go to the cool down phase. So this phase, again, similar to the beginning with the warm-up. We do 5, 10 minutes of cool down. And basically, it's gonna help you to recover from the conditioning phase. Your blood pressure will slow down, your heart rate will slow down as well. But again, the decrease of the intensity is gonna help you to just get back to your norm base. So just don't forget that you have to warm up and cool down. So again, benefits from the exercising, and it's gonna make you feel stronger, your heart is gonna get stronger, and reduce all the heart risks that we already know. But I think the main thing that I can highlight here is reduces the stress, tension, and anxiety and depression, the mood, because and the self-esteem. One thing that is very common in patients with heart failure is this. And when you are in these two situations, being anxious, being tense, or depressed, usually then you don't want to do anything. So you need to break the cycle somehow. What exercise tips I can give you is don't exercise when you just ate or when the weather is too cold or too hot. Again, don't skip the warm-up or the cool-down. Remember to drink water when you feel thirsty. And I know it's water restrictions and limitations, but you will learn that as well. You need to rest during exercise. You don't have, if you feel tired, you just stop for a few minutes, 1, 2, 3 minutes, catch up and keep going. And you learn your body, how long or how much I can stretch my body and press my body, and then I stop. But you complete the 20 minutes that you put as your goal, and then keep going. So slowly you will increase the level of exercise and demand that you want to impose to your heart and your body will respond to that. So again, very important, you don't exercise when you're sick, when you're having a fever, when maybe you are, you quit your routine for quite some time and you are just returning. Don't expect to do the same routine that you did a week ago or 2 weeks ago when I went for my trip and never exercised during those 2 weeks, and I just get back to do the same. Your body has been deconditioned. And that's something very important. In order to build, you have to work hard. In order to lose what you gain, you don't have to do too much. The fact that you are in bed, that you are not exercising, usually make you lose muscle, like a 10% of the muscle that you gain every day. So it's why you need to be out of bed, you need to be active. And mainly, have fun. So you need to choose activities that make you feel happy, that you enjoy, with somebody that you like. If you feel that's the motivation and my goal in life, so I can feel better. Let's see. So do different things. You set your goals, not your doctor. You have to commit to this, and the commitment is just be alive and have a good quality of life. So set these goals. Treat yourself. I see that sometimes we use the ugliest clothes we have, the oldest, to go and exercise, to walk. No, treat yourself. Go shopping, get a nice shoes just for the look, just to treat yourself and say, I'm going to the gym, I'm going to walk around with a very nice clothes and I feel happy. So treat yourself and have fun. Schedule your exercises as part of your daily routine and try to stick to the same time. So you know this is my breakfast, this is my lunch, or this is my dinner, and it's part of my life. So it's easier to do that. Maybe find a friend that can work with you, and as I say and emphasize, just have fun. Walking is important in case you don't want to just go and commit to a different type of exercise, but just walking is good and will improve your muscle tone and strength, and different things that can help with your heart with walking. 20, 30 minutes a day or as little as 10 minutes a day. But again, try to make it as a routine that I do. And every day you can increase a little bit more your goal. And you document your goal. And just share that goal with everybody. Say, hey, I started walking just 10 minutes. I was very short of breath. Now I can walk 30 minutes and I'm fine. Or I just did 2 blocks. Tomorrow I'm going to do 3 blocks. You set your own goals and motivate yourself. And I think I'm getting close to to finish my presentation. So a few tips about exercising, and I mentioned again, just plan everything. Take it easy when you are going up the hill because it's going to be down the hill too. So be realistic about your goals and try to stick with those goals too. Be proud of what you succeed. Regular walks are important, and talk to your doctor or your nurse if you feel like it's something not working good with me, or I'm not sure what I'm supposed to be doing when I'm walking, if you have questions. The weather is important because that can affect your heart and in general your body. And one more tips, and maybe what you not do when you want to be active. So basically, recognize your body and listen to your body. If you feel very exhausted, just stop and take a break. If you have a fever, infection, I think it's just common sense. You don't push through those events. If you have chest pain, of course. If you are going through a big change of medication or adjustments of medications, I will say let's try to skip the exercise until you are more stable. And if you're having persistent aches and body pains that are not helping. So overexertion can happen because I'm going to do it now, I'm pushing for the 30 minutes, and maybe my goal was not very realistic. So that's going to affect badly on your heart too. So you need to listen to your body and don't do it when you feel any of this. And the more you do, well, of course, you will enjoy more. And you will recognize the changes in your body about when you stick with your exercise program. I think that's it.
Don't go walking in the supermarket. But thank you very much for the overview, and hopefully we can walk up and down the stairs today. We'll go to the next topic of creating your care team, and we talked a lot about team and working together. What does that mean? And Mr. Riwan is one of our social workers who works closely in the transplant center, deals with a lot of patients and families going through a lot of stress. And she has been instrumental in helping a lot of our patients, and thank you for being here, Misty.
Good morning. How are you? Good. So today I'll be talking about creating your care team, or who's going to take care of me. This is why I had kids. No, I'm kidding, but I want you all to think about that. Kind of the care team is a culmination of everything that they've been talking about. Who is going to exercise with you? Who's going to help you take your medications? Who's going to take you to the grocery store if you want to go, if Dr. Galati allows us to go? Those are the things we want to think about. So who can be a caregiver? Anybody. I put on their relationships count. Always be nice to people. I think sometimes we feel like others won't help us, but what I find is there are always people willing to help others. Your family members, ask them, cousins, uncles, aunts, nieces, nephews, adult children, anybody who would be willing to help you, because this diagnosis is a big deal and you need help getting through it and learning to manage it. We've also found that employers, employees, neighbors, those are all the people that want to help, and you'd be surprised. And I know sometimes you don't want to tell people about your diagnosis, I don't know, but I find a lot of my patients, when they find out that they have been diagnosed, they do start telling people, and that's when people come out and they help them and they get so much more support than they would have thought that they have gotten. So it's out there. So now that you've identified your caregivers, now what? So we do have minimum requirements. I come from a transplant perspective, so heart failure is a little different, but you need somebody who you can count on, who's gonna be there, who you can call on 24/7 if something happens, if you're hospitalized. Those are the things I want you to think about. Can they be there long-term, or can you get a group of people together that maybe this person handles my dog, maybe this person helps me with my kids, maybe this person helps me pay my bills when I'm hospitalized. But letting them know, hey, these are the things that you need. And you as the individual with the diagnosis understands what you need. So be open and tell them, hey, I need you to do this. Because what you find is a lot of times they're willing to say, yeah, sure, I'll help you. Also, length of time for care. It just depends. Like I said, this diagnosis is a continuum. So think about that. There may be people for this point in time, and there may be people for another point in time. Also, the care of minor children and pets. Pets are family. We are getting a dog, and I'm scared because I know that he's about to be my baby. Oh, what did I do? Oh, they fixed it, okay. So it's important. Who's gonna help you take care of your pets? Who's gonna help you take care of if you have minor children? You wanna think about those things because those caregivers, those people are gonna help you do that. Also, things to think about. When you're hospitalized or something happens, who do you trust enough to give access to your bank accounts to take care of those financial responsibilities for you, pay bills, act on your behalf? And also, family members. If you work, most family members are eligible for FMLA, but what does time off look like? I want you all to think about those things, because those are important, because what happens is we don't, and then we're in the hospital, and it's like, wait a minute, I didn't think about that. So it's important to have those conversations. So That was it, y'all. Okay. We are stretched for time, so thank you.
Misty, thank you so much. And again, we'll spend a little bit of time having questions while the chef is setting up in a few minutes. Our next talk, which is the last one before the cooking demonstration. You want to do the questions now? Okay. Yeah, we'll answer a few questions here. I think Dr. Cook might have stepped out for a second. What does abdomen, so let's see, the first one is what blood pressure is too low and warrants call to the doctor? So it depends on what your normal has been, and it also depends on whether you have a low heart function or not. Typically, a lot of individuals with a low heart function I have a lot of patients who are walking around with a blood pressure of 80/60 and they feel good. But if you don't feel good, 80/60 might be low for you. A lot of people with the low heart function, if 70s, upper number of 70s, where there are two numbers, systolic and diastolic. Upper numbers of 70s in any definition is too low. I think that warrants a call. 911 or doctor, lay down, keep your feet up. 80s over 60s, some people do okay. If you're older, you don't feel that good with lower blood pressures. So if 90/60 is actually okay too, if you have a low heart function. If there's a reason to keep it low, I think you can keep it low. That is especially for people with a weak heart, because the weak heart can't pump against a normal blood pressure. But if you have a normal heart function, there's no reason for you to keep it at 90/60, then you don't have to. Then you have to back off on your medication. So that's where knowing your goals, that's another thing we'll probably talk about in one of the breakout sessions, is important. So we'll go back to the questions at the end. I want to move on to the next and the last topic with my friend, colleague, and mentor, Dr. John Cook. He's the head of the Heart and Vascular Research Center. He's a clinical cardiologist who has chosen to spend all his time doing research, and he's doing some phenomenal work in how to regenerate the heart, how to make the heart beat better, and a lot of exciting things. So I want to welcome Dr. John Cook to tell us how the future of heart failure can look like and update us on the innovations. John, thank you.
Thanks, Ivan. Thank you, Ivan. Thank you, Ivan. I'm supposed to be talking about the future of heart failure, but I'm very aware of the very immediate future. Right after my talk is a cooking demonstration. So I want to make sure we have plenty of time for that. So I won't take too much time, but I will tell you one story that's emerging here at Houston Methodist. I work with Arvin and the others on our team about a new development in our understanding of what causes heart failure and how people recover from heart failure, and how that might lead to new therapies toward regeneration and restoration of heart health. So, future of heart failure care. You heard a lot today about diet and exercise. By the way, Gladys' talk was great. I really enjoyed that. There's a little exhibit outside. The nutritionist has, like little vials of salt, corresponding to how much salt you get if you eat a hamburger, a Whopper, or something like that. And then she had these vials of lipid, and I picked up one of the vials, and it said cheese fries. It was like full, one of the vials. And I picked up another one that wasn't quite full. It was the chicken Caesar salad. And I was like, I'm having the cheese fries. No, don't listen to me. Listen to Dr. Galati. But I was surprised. It was very... I learned a lot from that exhibit of our nutritionist. Anyway, we've heard about the medicines. I won't go into much detail about that, but there's a lot that we can do today to improve heart failure, to improve how you feel with heart failure. And then as time goes on, if there's increasing problems, there's intravenous medicine that we can use, and left ventricular assist devices before heart transplant, and hopefully we can avoid those, but that is an alternative. What about regenerating the heart? Is it possible? Well, it is possible in lower vertebrates. Salamanders on the right, zebrafish, which we are studying here at Houston Methodist, they have tremendous ability to repair their heart. So we can actually induce a small amount of damage to the heart of the zebrafish. For example, we use a laser to do that. And you can damage the heart, but that zebrafish will fully regenerate its heart. It doesn't scar. How does it do that? I won't go into too much detail with this diagram, but I do want to just say that if we damage the heart in the zebrafish, it's able to fully regenerate the heart. How does it do that? The cells next to the injury change. They change from contractile cardiomyocytes, heart cells, and change their shape and structure and function and proliferate very rapidly and fill that area of injury. And then they regenerate back into, or differentiate back into heart cells to regenerate the heart. Turns out that humans can do this. We can do this, we can regenerate tissue when we're in the womb. So we have doctors that operate on children that are in the womb that have a hole in the heart, that have a congenital abnormality. And these are kids that are going to die without the operation. So the surgeon goes through mom's belly and through the uterus and into the womb and can operate on that child, go through the child's chest wall, the fetus's chest wall, operate on the heart, close the hole, and then complete the operation and sew up the mom. And then a month later, the child is born, and that defect is closed, the child survives. But what's interesting is that that child does not have a scar on its chest. It's healed with tissue. So it is possible for humans to heal with tissue. And every once in a while you hear about a child that have regenerated their fingertip after an injury fully with the nail and everything intact. So it is possible. So there's a lot of work going on right now in how to regenerate the heart after damage. Up at the top, there's been a lot of work with cell delivery, small molecules, proteins like VEGF, vascular endothelial growth factor, tissue engineering, building pieces, blocks of the wall that we could insert back into the heart, or reprogramming the tissues, much like the zebrafish reprograms cells in the heart to become functional heart cells. This is still in the development stage. The cell delivery is farthest along, but it hasn't been very notable. We haven't seen too much benefit from injecting stem cells into the heart. It's been a little bit disappointing. We need to learn more about the process of regeneration if we're going to regenerate the human heart. So we got to get back to first principles. What happens to the heart when it's damaged? So when you have a heart attack, one of the things that occurs is scar formation. So the healthy heart muscle is shown in red, and you can see these areas of white are areas of scarring after an injury to the heart. So that's what the heart looks like when it heals. It heals with scar. Same kind of thing here. And the scarred areas tend to thin. They tend to thin. They're not contractile. The scar areas are like more like a leather of a football. It doesn't contract. That process of scarring of the heart also occurs in another form of heart failure, and that is heart failure that occurs in the absence of a heart attack. Heart failure that occurs, for example, in long-standing diabetes or long-standing high blood pressure. You can get changes in the heart. And let me draw your attention down here to a healthy section of a heart. This is a microscopic slide. You're looking at a high power view, like 100x magnification. You're looking at the heart cells in the heart and a vessel. There's a small vessel. It's a capillary. and that capillary is only one cell layer thick. Endothelium is lining that, and the blood oxygenation reaches the tissue through these capillaries. Well, what we see in people with heart failure is this kind of picture where there's a lot of fibrosis, scarring around the vessel, shown in red here. That's scar with this kind of staining. And this kind of scarring process throughout the heart causes the heart to be stiff. It causes increased pressures in the heart, which back up into the lungs and cause fluid to accumulate. So scarring is an essential problem with heart failure. It's something that we have to solve. Now, the good news is that we are finding that this process is not irreversible. We used to think once you had a scar, it was irreversible, like a scar, in your skin. We thought it was irreversible, but there's now evidence coming from Dr. Bimaraj's lab, and our group is helping him with these studies. There's good evidence that this process is reversible. So this is a very cool idea, and congratulations to Arvind for making these observations. So this actually is a mouse model now, a mouse model in which Dr. Bimaraj has induced heart failure. So this is a piece of the myocardium. It's a section, again, a microscopic slide looking high power view, 100x magnification at the heart tissue. And you can see here in heart failure, there's this blue stain. Now, this is a different type of stain. It's staining the scar blue, and you can see scar throughout the heart. Well, these animals are in heart failure. Their heart isn't pumping as well, and they actually get fluid in their lungs, and they're not doing well. They're gaining edema throughout their body. But the animals can recover, and when they do recover, the scar goes away. If the scar goes away, the heart is pumping better. So, and here's the data up above, increasing scarring with heart failure. In the recovery process, the scarring is going away. And the heart failure drops, the heart function drops during the heart failure, and it goes up during recovery. So there's a relationship between scar and failure. So can we understand that a little bit more? Well, we have. Again, Dr. Bimaraj's group has taken tissues from our patients that are having a left ventricular assist device put in. So at the time of the left ventricular assist device, you can take a little piece of tissue and you can study it under the microscope. And then later, when the patient is going for their heart transplant, you take the left ventricular assist device in the heart out, and now you got more heart tissue to study. And the interesting thing that Dr. Bimaraj has observed is that scarring occurs in the heart in someone with heart failure. You can see this diffuse scarring. It's in this stained in blue in this microscopic slide. That's all scar. But at the time that left ventricular assist device is taken out, the heart has been supported by this left ventricular assist device, and during that support, the heart can recover. And with that recovery, scar has disappeared. It's reduced. This is the data. So there's a drop in fibrosis. There's a drop in the scar cells, which are called fibroblasts. There's a drop in the numbers of fibroblasts. Here's the interesting thing. There's an increase in endothelial cells. Endothelial cells are the cells that form small blood vessels, those small capillaries in the heart. So this is in patients. So in humans, the scar can disappear, and you can get an improvement in the blood vessel. Well, improvement in blood vessel means improvement in perfusion, better blood flow. And that's associated with better functioning of the heart. So now we have come up with a new concept regarding heart failure recovery. So the recovery from heart failure, we believe, is at least in part a recovery of the vasculature, a reduction in fibrosis, a reduction in scarring, and an increase in the blood vessels, and an improvement in blood flow throughout the heart. And helping us with this project is two of my junior faculty, Dr. Shu Meng, Dr. Lily Lai, and Arvind Bimaraj, and Kai-Fu Chen, who's a bioinformatician who can take the huge amount of data we're getting now from our biology and turn it into knowledge and wisdom that we can work with. He's the sharp tip of our spear. So in my laboratory, this is what we've been able to do. We've been able to take scar cells and we've been able to transform them into vascular cells. So this process of reversal of a scar, we believe, is due to the transdifferentiation of these scar cells into blood vessel cells that can form a vasculature. So instead of forming a scar, you can now form a vasculature, scapullaries, and they provide the nutrition and the niche for true tissue repair. So we think that we can prevent or reverse scarring, improve blood flow to the heart with this process. We've published on this. We've got proof of concept that it can work now in human cells and in animal models that this process occurs. Well, don't bother looking at this slide. It's really complicated. Let me explain to you what we found. The general concept is this. When a cell, any human cell, is confronted by a challenge, be it a pathogen or be it damage, it can sense that. It can sense that damage, it can sense that pathogen. That's known. We didn't discover that. There's pathogen-associated molecular patterns, damage-associated molecular patterns that the cells can sense. And in response to that, they can release factors that cause inflammation. That's known. What we discovered was that the cell opens up its genome. It opens up its genetic toolbox, so it can reach back into its genetic toolbox and pull out whatever it needs to survive or adapt. There's an increase in cellular plasticity through this mechanism. And we're working out now an understanding of what is allowing a cell, a scar cell, a fibroblast, to become an endothelial cell, a vascular cell. We're understanding those processes. These processes work great in salamanders and zebrafish and in babies that are not yet born. And this ability to change cells, this cellular plasticity, the ability to change from one cell to another cell, in this case to improve perfusion, blood vessel formation, this process we're beginning to understand, and in which case we might be able to modulate it. What this piece shows here is this opening up of the genome. The chromosome is a long thread of helical DNA, okay, the chromosome. And I'm getting a signal now, I gotta stop. I could talk about this all day. But to make a long story short, what we're doing here with these processes is opening up the DNA so that we can modify the cell plasticity. And this could be useful if we can generate, we have generated a small molecule cocktail. If we can do this in patients, we can change scar cells into vascular cells to improve blood flow after heart attack or someone with heart failure and treat fibrosing diseases. So I'll end there. This is the team that's been helping me with work in the Center for Cardiovascular Regeneration. Thank you for your time and interest, and I'll take any questions if there's any time.
Thank you, John. Let me make sure. We're running a little late. We have our chef who's going to start setting up everything. While we're setting it up, we can take some questions and have a discussion. So let's see what we have. I think we're going to go from bottom up as the questions are coming up. Why does the abdomen swell with heart failure? It's a part of congestion, which is the fluid buildup. And when Dr. Hussain talked about fluid buildup, in some people the fluid builds up in the legs. In some people the belly swells up because the fluid is all backing up. And in some people it backs up into the lungs. And it's when you're present, and it's very variable. And what we sometimes see is younger individuals have more of belly complaints. It's not uncommon where 18-year-old kids have congestive heart failure because of myocarditis, and they're going to a GI doctor and getting a full evaluation, and then somebody notices the heart's big. So it's a part of the fluid backing up into various organs, because as it was shown before, blood is flowing to the right side from the rest of the body, going into the lungs and going to the left side. So if the fluid backs up, it backs up everywhere, but it depends on where the cause is coming from. If the main problem is the left side, typically it backs up into the lungs first, so you're short of breath or not able to breathe first. But if the problem comes from the right side of the heart, the fluid first backs up into the liver, and that's where the belly swells.
Could I take this supplement?
Yes, yeah, and the other question, I think John's perfect. Dr. Cook actually has a whole legacy on supplements and the things which he's an expert in, so he'll answer the DHA supplement replacing eating fresh food.
We actually have a journal issue coming out of our DeBakey journal on supplements. It's coming out, I think, next month. But DHA supplement, that's basically fish oil. So krill oil is the best kind of fish oil supplement, and the reason for that is that you avoid the problems with what fish are taking in the water. Fresh fish may be a source of omega-3 fatty acids, but maybe not. The ones that are not are the ones that are farm-fed. Farm-fed fish get grain, so they don't actually have much omega-3 fatty acid. Fish actually don't make fish oil. They don't. They get it from plankton or krill, from eating krill. So the best fish is fish that's wild-caught.
Thanks, John. I'm glad he's here. I wouldn't have been able to answer that question. I don't know anything about fish and krill. Does it matter what time of the day you take your medicines? Typically, if you're taking medicines which are 2 times a day, they're designed to be spread out 12 hours apart. If you're taking it once a day, they're designed to be once a day, so it actually doesn't matter what time of the day you take. They're in your system for 24 hours. The only pills which have a time association are cholesterol pills. If you take cholesterol pills at nighttime, in the evening, they seem to work better on certain pathways. Apart from that, rest of the medicines don't have a time association. The other one, if taking meds make you feel sick, can you take them in the afternoon and then before bed so that you feel to sleep through feeling bad? Hopefully you shouldn't be sleeping through feeling bad. And that's another important thing that probably answers the question from the previous question. But if you're feeling bad with the pills, you want to identify the reason why you're feeling bad. Pills are not designed to make you feel bad. If they're feeling bad, it's not like I tell my patients, if you're dizzy walking around like a zombie, it doesn't matter having a great heart because it's meaningless life. But you want to drill down why you're feeling bad. Is it because I'm queasy? Is it because I'm kind of dizzy? If you're dizzy, is it dropping my blood pressure right away? As we talked about, heart failure medications can drop the blood pressure, but there are tricks to avoid in spacing them out or cutting down the doses, playing with them, trying to have another alternative option, which unfortunately makes it a little bit of a trial and error and working with your physician. So don't accept feeling bad as an option. Some medications take a little bit to get used to. Those ones, as long as you've ruled out other reasons, you might want to ride through it for a few weeks. Is heart failure reversible, and if it is, at what stage could happen? So that's a valid question, and the reversibility has various layers to it. If your heart is damaged because of a heart attack to an extent where there is no reversibility, which is a scar, at this stage, we don't have therapy that I can say it will reverse. If your heart is not damaged because of a blocked artery and the rest of the reasons where you can have things like myocarditis, sarcoidosis, other reasons, genetic predisposition, we still don't know who will reverse and who won't, but it's feasible to reverse. It's time and medications, and all the medicines that May talked about as mortality benefit, that's what they're doing. They're trying to heal the heart so it reverses. But again, our goal, our research is to understand the mechanism of reversal and healing so that we can devise something to enhance the healing mechanisms. But right now, we don't have anything we can just inject. Is shortness of breath at the beginning of exercise is different from shortness of breath at the middle of exercise significant? I think if it is related to the heart, that's something to acknowledge. Your shortness of breath means you're not able to catch air, can range from heart disease to lung disease to both, to overweight to out of shape. A lot of things can make you out of breath. Sleep apnea, pulmonary hypertension. But in general, if you're out of breath just on the beginning, it means that you're sicker than out of breath at the peak of exercise. Now, sometimes if you're out of shape, you might kind of get over the initial shortness of breath, and then you might feel better. But I would not ignore that if you have a condition which can cause you shortness of breath. CoQ10, you want to answer that? Okay. Yeah, so I think as John said, so CoQ10 had shown some promise in some animal studies on helping with heart failure, but right now there's a lot of evidence that showed there's really no documented benefit. There's no harm, so if somebody wants to take it, I say, as long as you're not spending a lot of money, I don't care. But there's no harm, and there's no benefit if you take coenzyme Q that it'll help your heart in either way. Stem cell therapy for heart regeneration.
I would be happy to take that question during the lunch break, but I think we might be ready for the demonstration.
Elliot, how are you? You guys are ready? Almost? Chef's here. All right, I think it's time to move on to the most exciting part of the day. It's my pleasure and honor to welcome Chef Robert Del Grande and then Elliot Kelly. Both are phenomenal and have been helping us out in doing this for the last 3 years from the inception of this conference. Both are chefs at Cafe Annie restaurant in the Galleria. My first conversation with Robert was very intriguing, and just a snippet, he has a PhD in chemistry, and then we had conversations about salt, and he probably knows more about the sodium than I do, and he has brought a lot of value into the culture of cooking. And we'll have Angela Snyder, who's our dietitian in Wellness Center, and then Joe Galati, who's an expert in eating. And I think we will have a perfect medley of all of them take it away and then tell us how to cook with low salt and then how to cook healthy. Chef, thank you very much for being here.
Thank you very much. Thank you. This will be a bit of a team presentation where I get to do some talking, and Elliot Kelly will do a lot of the demonstration over there, so it comes out right. We got him on that side, and then any tough questions, we'll go to that corner over there with Angela and Joe. So I'm just in a completely defensible position. No tough questions. So great. So let me start with just a little bit of how I get confused, so that as we go along and get confused about things, it's just part of the English language, but that we'll quite often say something tastes good or something has great flavor. You kind of switch taste and flavor around, and they're sort of English words as opposed to big scientific words like gustation and olfaction and things like that, more specific. So a lot of times I'll say something, here's how you make something taste very good, when I actually mean this is how you make something flavorful, and vice versa. The reason for that is that, more strictly speaking, taste is on your palate, and flavor is in your brain, and this will be in your mind. This will be a key part, I think, to cooking without sodium, is teaching your mind to perceive things differently. So on your palate, you'll have the ones we always learn: salt receptors, sweet and sour and bitter and umami, and that taste sort of part. But there are other ones too that are very important, textural ones, the feeling of it, and even things like temperature seems to have a big effect on how things taste. We were talking earlier that there's hot coffee and cold coffee and lukewarm coffee. It's all coffee, but it seems to taste different depending on what the temperature is. So a lot of times you'll see with food, some foods taste very good hot, some taste very good cold. So it's an important part of your palate. And above that's your nose, the smell, which is probably the aroma of the food, is the biggest part to identifying how things taste. And probably the one that's underlooked in cooking. People seem to want to concentrate on the taste of it and forget to manage the smell of it. So the smell is a really big one. Highly aromatic, beautiful taste, smelling food tends to taste better. And your nose really couldn't care less about sodium. It doesn't need it at all, so there's probably a key to that, to the aroma of the food. Then from there, a little higher up, you have the sound of the food, the sound of taste, the sound of flavor. If Elliot ever comments on things that I cook, he always leads off with, "I think you need a little crunch." Is that right?
Yes, that's correct.
We always
it's a
told him
balance, you know?
Yeah, a little crunch, you know, and I think he just loves the sound of the crunch that kind of makes it taste good. And there are a lot of foods that are very dependent on the sound of it, that it sounds like it tastes so good. So I think that part is key. And then our eyes, you know, the sight part, and it's simply because there's very few things that look terrible and actually taste great. Most things we just get used to seeing them a certain way. But even there, it's an expectation device that kind of clues you into things, I think. And again, the hard part about sodium and salt is that rarely can you see it very well. So a lot of times you can make up visually for how things look. They'll taste better if they look really good. And then finally, the great mystery is your mind, the perceiving part, making the perception. It has to assemble everything. So it's getting all these inputs from your palate, from your nose, from your ears, from your eyes, and it has to put them all together. Not only that, your mind tends to add a lot of other things to sort of memories and so forth get mixed in. I always say people's favorite foods are just an indication of their entire history, you know, where they've sort of been along the way. But also your mind is funny. It's like it's an expectation device. It expects certain things. It's also, I hope this is correct, but it's kind of a craving device. You know, it likes to crave certain things. And like, what is a craving anyway? It's, you know, I mean, it's like, man, and I really feel that, like that. But that can be changed, you know, and sometimes the flavor of salt ends up just being a craving. You just sort of crave it because it has a sort of an impact to it. And so when it's missing, you sort of crave it more. But if you uncrave it, if you uncrave it, then it's not as much of a problem. And so the mind then is looking sometimes for things that are missing and wants them to fill in, and quite often salt can be one of them. And what happened with salt in cooking is that it's a great filler-inner for things. If things are lacking, you just add salt to it, and your mind perceives it as, that's pretty good, you know, and so then all of a sudden it just tastes better. So if you let that go long enough, you just learn to add more salt at the beginning of everything and forget about managing the other aspects of taste and smell and sound and so forth. So and I mean this in the nicest way, like salt is really sort of cheap and lazy is what it is when it comes to cooking. It's very easy to do that. We were talking about chicken stock earlier, all of them were high, very high sodium. And the reason for it is that if you put salt in water, it'll start to taste like chicken stock. It's a funny thing, but your mind says, okay, it ain't water anymore. Now it's this. So the motto we always use is that always add the salt when necessary at the very end, not at the beginning, to fill in the spot. But you really are victorious when it doesn't need any salt at all. You know, so if you cook something with no salt and it tastes great, then you are really good, right? If you're not very good, add a lot of salt in the beginning. So at least the challenge is sort of there. So we have to always think about how the minds work, and that it can be rearranged. It can be taught to uncrave things, possibly. It takes a little bit of time, but it can work. Or also just be given the illusion that there is salt there when there's none at all. And that's what we're going to try to do today. So a little bit what we're going to cook today is based on an idea that I thought a mystery at first, was that there are some foods that taste really great and don't require any salt at all. They require no salt. So how can that be? I mean, why would your mind put up with that? that it has no salt at all. And so the usual ones you go to right away are fresh fruits. So fruits, all of them are basically, right? Yeah, they're really low in salt.
There's those people that put salt on their watermelon. That's the one exception.
Yeah. And actually, that's a perfect example which we can address, because the interesting thing about watermelon, it actually has the word water in it, which we're going to see in this recipe, because if you could modulate the amount of water in an ingredient, the need for salt goes down, right? The more water there is, so the way you make bad chicken stock, here's the recipe, easy. You put 2 chicken wings and a gallon of water, and you just boil it, and then you put a bunch of salt in it. So if you do 2 chicken wings and a quarter cup of water, it's pretty good. Or the mistake is you make a lot, then boil it down. But anyway, so fruits naturally taste good without any salt. And why? Well, it's for this reason, so simple. They ripen. And so when they ripen, an unripe fruit is something with potential, but out of balance, usually bitter, very sour. To Elliot's point, crunchy is not hard. Yeah, crunchy is crunchy, crisp is crispy, but they're usually very hard. And they don't smell like anything. So in the market, people will pick things up and want to smell them. As they ripen, the texture now becomes a little bit crisp and firmness to it. The acidity kind of goes down a little bit, the sweetness goes up, nice balance, the bitterness comes into, everything starts to come into balance, right, which is sort of interesting. And guess what? They start to smell really good, right back to what we talked about, to the point where they don't need any salt, because acidity and sweetness and texture and smell have compensated for all of that. Under ripe fruit, people will add a little salt because it's missing something. So think of it this way. This is the metaphor. Cooking is like ripening, right? It's bringing something to a higher form of perfection. It's a nice idea, but so for fruit to ripen, they use the energy of the sun. So the sun's the stove that's making them so ripen. When you go to vegetables, also low in sodium, they don't tend to, it's not kind of a ripening area as much. Some aging thing is there. So then cooking now really becomes the form of ripening of the vegetable when we cook them. So what we have to do, and what we're going to do today, is to demonstrate how we're going to mimic ripening of fruit in the vegetable category that we can use for other things. That's the whole idea. So to start, well, one quick one, and this is obvious. If you take an onion, for example, a raw onion, it tastes and smells like a raw onion. And when you cook it, it dramatically changes, right? The texture changes. And what happens is that the texture changes, they get sweeter for sure, and they really get aromatic, right? And the slowly you cook them, everything smells lovely, so this sweetness just from the natural sugars that are there. And they also sort of reduce in size, right? They start to concentrate, so they keep tasting better and better and better. So that's like when you cook an onion, you're kind of ripening it is what you're doing. You're making it seem like a fruit. The acidity is nicer now, it's sweet, it's aromatic, the texture is sort of luscious. So it's a good model to follow. Today, Elliot's going to do zucchini, and this is back to the water piece, which is kind of fun. And he's going to sear them. You going to sear them first?
I'll sear that first.
Don't worry, there is a fire extinguisher, but don't worry, he's fine. So he's going to sear them first, and the whole idea behind searing is two things, that when you, if the sun makes the fruit smell better, the fire in the hot pan will make the vegetable smell better. So the searing part is going to give you aroma, and that's the first thing that's going to reduce the need for salt on it. The second thing is going to be that it's going to cause the vegetable to dehydrate a little bit. So everything is starting to concentrate. Sometimes with watermelon, if you cut thick slices and put something heavy on them, on the slices, it pushes the water out and then they taste better if they're not quite ripe all the way. So it's just, you just have to remove the water from them. Then you just drink the water afterwards. So he's going to start by doing that to get a sense of this roasting and cooking. And I do it quite a bit. And at home, it's really simple. You can do it even under the broiler and the stove, and it's very little work, but they're going to get this this great aroma and then this concentration of flavor. Then we're going to mimic, you're going to make the little vinaigrette. You can do both at the same time. You do two things at the same time? So
I'll try.
Yeah, you'll try. Okay. The difference between professional cooking and home cooking is you have to do two things at the same time when you're sometimes five things at the same time. So we're going to make this little vinaigrette, and what I was looking for here is something that mimicked a fruit that you could use instead of putting salt on something to make it taste better. You put a little bit of this vinaigrette liquid thing on it. If you think about Tabasco sauce as sort of, it makes things taste better because it's spicy, which is an impact on the temperature receptors in your mouth, and the vinegar makes it taste better. So we're going to follow that. In this recipe, and I like to use, to get as much impact as you can, it's going to take citrus fruit, which do ripen, right? On the tree, they're green, and then the lemons will turn yellow and oranges orange. We're going to use not only the lemon juice for the acidity, he just added some honey, which is going to balance the two. So it's a lot of lemon juice that behaves a little like salt. It's electronic. It gives you this feeling on your palate to the point where I can't drink that much straight lemon juice. The honey then is going to balance it. So the feeling is still there, but now your brain doesn't perceive it as just being sour, it perceives it as sort of sweet and sour. He's also going to add the...
I just added the lemon zest.
Yeah, the lemon zest. You added it already? He's going to add the lemon zest from the outside of the lemons, because that's where all the oils are that really smell like lemon.
Can you comment? I saw that he put olive oil in the pan. Can you comment on virgin, extra virgin, non-virgin olive oil and taste and flavor and what to do?
I only take true-false questions. Yeah.
All right. True or false? Extra virgin tastes better.
Yeah, so in olive oil, they'll go, like any other agriculture product, there are ranges of them. The highest ones, olive oils, they're very concentrated for sort of finishing olive oil for flavor, very pungent, and they should actually be kind of spicy. In fact, a few drops of olive oil on something takes the need of really good olive oil. So it looks really expensive, but you just need a little bit, and there's this punch of flavor and aroma, too, that lessens the need for salt. But you never want to cook with those. Further down, as you go down the line, that when you cook them, you heat them up, you kind of destroy some of those high aromatics. So the lowest ones are just utility oils, which would be olive oil, which is kind of really unregulated. It really could be anything, hard to sell. And the lowest, pumice oil is the lowest one, which, you want to oil your baseball glove, that's a good one for that, But most of them have now moved up in the virgin olive oil category, which is more regulated depending on ripeness and acidity and so forth. But you can just tell by the price. You can see olive oil for a can for $12 or a little bottle for $50, so they're all over the place. So does that good answer to the question? But it's a great flavor modifier. Instead of going for the salt, a few drops of olive oil, a really good one, can really boost the flavor. Another way to boost flavor is what Elliot just did. The blender can be your friend because you can get things from the solid form to a liquid form, which is good. In this case, he blended the honey and the lemon, right, and the lemon peels to get this explosion of lemon. Now the lemon, instead of being sour, is going to be like this intensely ripe kind of lemon. We've ripened it. The olive oil to it is then going to give us this palate feel, this lusciousness sort of, and a little bit of the luscious sort of piece to it. Then there's a bunch, so now he's going to manage the smell. So I like to go to the spice rack, and my favorite stuff is, so coriander seed, either raw or toasted, you can lightly toast it, is a very citrusy one. We're going to add some fennel seed to it, which again is, you tend to smell it more than taste it. There are going to be some chili flakes in there for the spice, a little impact. And these are kind of things that we're saying, you could measure it or just, put some in there. Nothing can really go wrong. And then there's some pepper and there's no salt. And what am I forgetting? I'm trying to go through everything.
Rosemary.
Black pepper. Yeah, black pepper. So for a little bit of the bitterness and a little bit of the bitterness from the peel, the sweetness from the honey, the sourness from all these taste things. The smell then, we're going to go up. So the feel of the olive oil. Then the smell, the fennel seed, the coriander. Then he's adding herbs, your choice. And herbs are great because they're just going to add this great perfume to it. He's just going to blend them up very, very quickly where all the flavors sort of expand. Then he's going to plate up the zucchini, and we'll just pour this little vinaigrette over it. And I want it to be not a very strict recipe, follow it exactly as written. No, just kind of play around with it. If you want to use limes instead, grapefruit, something, but think about mimicking how a fruit ripens, and it's going to somehow attach everything along the way. It's going to have this sourness, a little sweetness, a palate feel, a touch of bitterness, the smell, the aroma, and it'll look really pretty as well. And it's, I think this is simple enough that even I could do it, to tell you the truth, but Elliot's better than me at it. So anyway, that's sort of the idea, and we're going to have them at lunch. The two. So I made another one with brown with dried fruits. Same sort of idea. Borrow from fruits that are tasty and don't need salt, and then bring it to the rest of the food. Good on fish, good on chicken, too. Questions? Or questions? Yes? I got the word guilt, so I'm already interested.
For you and Dr. Galati, do you have one guilty pleasure food that you'd like to indulge in that you know really isn't good for you?
You first.
Something, an unhealthy food? Hamburgers. Hamburger with...
I guess, hamburger with cheese on a bun. That's probably like the worst thing I would feel pretty bad about. Sometimes a little bit of cheese.
Just got
Is that a good answer?
I think that's a good answer, yeah.
Are you waiting for Bluebell or something like that?
No, so I
Gotta ask
think...
Angela here. What does she say? What's your worst food?
Not hamburgers. That one's easy for me to not do. Gosh.
Well, here's I guess when you say guilty, I'm thinking it's got to be high in salt and high in fat. I'm sure that's probably the starting point to it. And actually high in everything is how it turns out. The key to the guilty, because I never think about foods as being good or bad. I always think about how much, right? So the key to guilty foods is simple. Share it with somebody else. So half a hamburger, and you're halfway better than you were. And for some reason, two guilty people are awfully innocent. For some reason, I think you could. But at least I think that's the problem if you think it's going to be like the hamburger, particularly in America where we do tend to think if it's good, bigger should be even better. You share it is always sort of a good idea. We'd like to share this, so.
Absolutely.
And then that sort of ties to, if you can, try not to crave the guilty stuff. Maybe that's it, Crave the really good stuff, and then the guilty stuff, you feel like you deserve it, Any other questions, or?
That brings that sweetness out. So it makes things taste better, just like you doing ripening in the process of cooking.
Okay, so the question was about what happens in a fruit when it ripens that makes it taste sweeter or better and so forth, which is a great question because it's the same with cooking, that overall in taste and smell, the molecules have to be smaller. We don't really taste stuff that's really, really big. So you can think of big molecules, starches and so forth, as potential for something. And then even though it uses the power of the sun, the fruit stays pretty much well below cooking temperatures. It's always sort of enzymatic. So these things are getting broken down, and the further you break down starches, eventually you end up with sugars at some sort of point. So that's the sweetness. The aroma, too, those molecules, aromatic, tend to be smaller, so they're generated in the process. Same thing in cooking. When you cook an onion, not only some of it is releasing the sugar, some are broken down, and then they start to caramelize, which is another reaction, which you'll see in fruit sometimes too, these other enzymatic things that generate this caramel spectrum of all these little tiny molecules. So the whole idea is you're thinking about, I'm generating it by breaking down what's there. Sometimes you can add a pinch, like if you add a pinch of something sweet and let it caramelize, it'll get even more aromatic. You can do it with sugar. You put white sugar in a pan, and it tastes like white sugar. It tastes like one thing, white sugar. Then you slowly heat it till it caramelizes, and it tastes like 1,000 things, which is why in sometimes Chinese cooking, you'll always see this little burned sugar thing that they'll add some vinegar to. In fact, if you want a nice little sauce, it's called a caramelized vinegar sauce. You let the sugar caramelize, and you add vinegar to it, like brown sugar, caramelized little vinegar, and you get this intense sweet and sour sauce. But the two things taste like sugar and vinegar together, pshoo, and then you don't need any salt because it works pretty well. Other questions?
I don't think I need this. The city of San Antonio, the Metropolitan Health District, and the Restaurants Association and the Texas Nutrition Association have gotten together and come up with menus for restaurants to have that are healthy, and they have limits, on them, like how much salt and stuff, and calories the meals can have. Is there any, and Dallas is also doing this, is there any way that Houston's been getting ready to do this or starting something like this?
I can answer that, I
Yeah,
guess.
there you go. Yeah, sure.
I think that's one of the missions that we're working on, and I think actually we've had conversations, Robert and I, and Dr. Cook, who stepped out. We had the mayor here for one of the conferences, and I think the intent is really to change the culture of cooking. So a few things. So what you're talking about is probably imperative and necessary. We want to take at least small steps in aiming to have a focused education during Heart Month, during heart failure awareness, and then lead to some kind of a implementation where you can direct those menus. And then again, what we are also talking about is, can you change the culture of cooking, go to the culinary school, and as it's not just we trying to change the menu, but can you work with the nutritionists, with the medical team, and change the culture of cooking? So it's a very valid question, but that kind of a public health perspective is necessary. We're not there yet.
Mm-hmm.
I do think it is the culture, and from my perspective with patients, I have patients that eat out 7 nights a week, and for whatever reason, they're not cooking at home. They feel very uncomfortable cooking at home, and so one end of the equation is to get people to cook more at home. The other thing is portion size. So a meal that is a quarter of the size may not be as inherently bad for you, but if you eat the entire plate, it's horrible. So if we talked a lot about salt and fat and calories, and if something has 6,000 calories and you make it a third, that's only 2,000 milligrams or less than that. So there are many parts to this problem, and I think there's many ways that we can attack it to get to that end point that we're looking for, which is better health for everybody.
Well, and I think too, it has to be demanded by the consumer. If present company excluded, if other restaurants, if they're making tons of money off fried chicken and hamburgers and everything else. What's the incentive for them to change their methods of cooking and to change the philosophy behind their cooking? And so ultimately, it has to be consumer driven. We have to be vocal about wanting these things, either from a local level, a state level, but also just individually in restaurants you like. Go ask them, hey, do you have any other healthier choices to offer? Can we start putting some more vegetables on the menu? Whatever the case may be, I feel like a lot of it is really consumer driven, and if the more we want that, the more the restaurant industry will start making those healthy offerings.
It's a long road, I can tell you that, because there's the knowledge base going all the way back deep into the kitchen. The weakest link will ruin it, that someone just doesn't get it and they just, I don't know, or what they've been used to. So it would take a while to get that really to work. But the first step, too, is the way I always find it interesting that all you want to do as a consumer in a restaurant is to say, I would like control over these things. So I'm always amazed at, I thought that the person that asked for the sauce on the side didn't really want the sauce, but we're going to send it on the side anyway. Then they come back and say, can we have more sauce? I said, well, if they like it, why didn't they just have it on there in the first place? But it wasn't about that. It was about control of it, sort of. I want to put it on. I don't know how much it's going to be or not. So I think sometimes you could, if you think about salt, that when there's salt and pepper on the table, you could look at it like this by saying, oh, I assume there's no salt and pepper in the food. But there is already, so why is it on the table then? It would seem like if you're going to put it on the table. So you'd almost want to say, I want no salt on my food and just give me a little bit and let me control it. So the first step is probably trying to switch a little bit of where the control is. So for us, what we do, we don't put salt in anything, chicken stock, anything, no salt. And so you'll taste the chicken stock and you say, yeah, it's kind of missing something. Yeah, it should be missing something. We didn't put any salt in it. And then we'll decide at the end what we're going to do with it. So it'd be a long process, but if the customer kind of was asked for, I think, more demand over control of food, then that will transfer further back to the kitchen. Versus trying to drive it from the back forward may be harder. You need to kind of do it both ways.
They're getting hungry.
We'll go on for hours, and you'll starve to death is what will happen. But
anything else? We're good.
Thanks you, Elliot, for doing that. It was great.
Yeah, as a small gift, a memento for the chef.
Thank you.
Elliot. Thank you very much. Again, it takes a lot of effort for the chefs to pick up, come here, set it up, and thanks for being here. We appreciate all your insight. And then I think they've made a sauce that you will get to taste outside during lunch. And we're coming to the end of the morning session. I want to remind you all, once we split for lunch, at 12:30, there's a caregiver support group on the 5th floor. So whoever are caregivers can take a break during lunch, go up there. Misty and Heather are going to be available in the breakout room for you to have a small group discussion on how to be a caregiver and other things. And then at 12:50, we'll have the expert-led discussion small groups up on the 5th floor. There are 4 topics. One is medical aspects of heart failure. One of my colleagues, Dr. Cassie, will be there, and then Achi May will be there, where you can sit down and have discussions of what are your medical questions related to the heart failure and the heart. And then there's another room which is food and nutrition. Angela and then Dr. Galati will be in that. Heart fitness and then physical fitness. Ala is one of our physical therapists, and Wayne Brewer, who I had introduced earlier, is Wayne, are you in the room? He's outside. Yeah, Wayne's also a physical therapist, but he's the one who's running the support group, and he's been on both sides of the fence. he has congestive heart failure, so he's the one who was in fact responsible for a lot of this work that we started together. And we'll have Bearing the Burden of Heart Failure, where a few of our nurses, Tracy, and looks like, and then Heather will also be there to kind of talk about how do you cope with congestive heart failure. The intent is you'll be broken down into groups of 15, 20, and you'll rotate through each room, so you'll get to be in each room. It's about 20 minutes in each room, and there are, our team members will kind of time you and move you around. And at the end of lunch, there are stickers on your name tags, which categorize you to your color. So they'll have a placard which calls the color, so you just follow them and go to the rooms, and once you start, you'll rotate through and finish up. So we will not come back down here, we will adjourn from there, and there are questionnaires for you to fill out, survey at the end of your last breakout, so we can get some feedback. And I know we ran over, but if you have any questions, use the small group sessions, otherwise come and grab us. But before we wrap up, I really want to thank the DICET staff that you see. Mariana, who's running around, and the other staff who are in the background in black. DICET is the Institute of Education, which has a YouTube channel where you can in fact go back and watch all these videos and watch the sessions from the last couple of years, and a lot of educational information, and they've done a phenomenal job. I also want to thank our nurses who are also in black scrubs from the hospital and our clinic, who helped out a lot, and I want to thank my assistant, Janet, who's at the back, who's helped with a lot of this efforts. So it's a multidisciplinary group, as you've noticed, our physical therapists, our speakers, and of all, thank you all for making the time, and have a...
Thank you, Dr. B.
Please.
By a show of hands, can I get an idea, or if you can just raise your hand if you plan on going to the caregiver group upstairs? Okay, perfect. Tracy will actually walk you guys up. I'd like to invite Heather Chung, Misty Riven to go ahead and head upstairs. What I recommend, if you are a caregiver that wants to go to the support session, please go ahead and grab your lunch, and you can take the elevator up to the 5th floor. As I mentioned, Tracy right here. Tracy will be right outside, and she will walk you guys up. That way you can get started on that. I'd like to go ahead and invite you guys to come out. And as Dr. B. Mirage mentioned, each of you has a dot on your name badge. Actually, I'm noticing that some of you don't have a dot on your name badge.
I was actually at another institute for treatment of my cancer, non-Hodgkin's lymphoma, and I knew that a realistic part of having chemotherapy is that you could end up in heart failure, and the risk is low, but it can happen and it's very real. While I was at the other institute, I really kept feeling like something was wrong. My heart, was building enormous amounts of fluid, and I was discharged from there, went home, and just one more pillow after another I'm sleeping on, and I finally said, I have to go to the A team, which I knew was DeBakey, and I needed to be here at this institute to be evaluated to see what there was, and I was in true heart failure with an ejection fraction of 28, 29, somewhere in there. So that's how it really began, and I spent a week with the team, a little over a week with the team, and I'm here now.
I was diagnosed with heart failure April of 2014, and what prompted me to go see the cardiologist was because over a 6-month to 1 year period prior to that, I just started having very gradual symptoms like fatigue. I couldn't exercise quite as long, but they were so gradual, so subtle, that it took me that long just to realize that something was not quite functioning the way it should be. The biggest cue was the fact that I used to go out and run. I used to run a lot. I'd go out 5 or 6 miles, and gradually over time it got down to the point where I was struggling with just 2 miles. And so at the time, I think I was just entered my 40s, so I was thinking the typical, I'm at the middle-age stage and maybe I just need to cut down type of thing. So actually I switched my workouts to doing more short, intense workouts, and I was doing really well with that. but it was still just this persistent fatigue. And then also even at rest, I would find that I would feel the heart skipping beats. And then that's when I realized that something wasn't quite right from a heart standpoint. And then there's even a couple times I felt a little dizzy or even a little lightheaded.
So 40th birthday, had a nice relaxing morning in bed, reading a book. Started not feeling well. I was 6 weeks pregnant, and I thought maybe, I'd never been pregnant before, so I thought maybe it was the pregnancy, I just needed to eat. And it just got worse and worse to the point my husband took me to an emergency center, and they said I either had a stroke or complex migraine, which we all assumed it was a complex migraine, young, healthy. So I had to go to the hospital, get an MRI, and they confirmed it was a stroke. Later that evening, they told me it was because I had heart failure. It was hard to put the two and two together. It was supposed to be a happy time. It took us 5 years to get pregnant. We had only known I was pregnant for 9 days when I had my stroke. We did in vitro. So, yeah, it was hard to comprehend everything that was happening. The first night I was diagnosed, a doctor had already told my husband that I would have to terminate the pregnancy. I found that out later. We got a second opinion. We went to Cleveland Clinic, and they put us in touch with Dr. Park, and she and her team were willing to take our case on. So there were, of course, medications that I couldn't take because of the pregnancy, but we found a regimen that worked, and it didn't really get too bad until my 3rd trimester.
It is a tough diagnosis to have, but realize that it's not a time to retreat or a time to feel defeated. It's a time to now stand up and fight for the life that you want to have. You know, it's very easy to succumb to the thoughts of having this severe disease, but at the same point too, every day is a gift, and you want to live the best life you can. In order to do that, it requires now some careful daily work in order to have that. And that's what I would say to anybody dealing with heart failure, is that having a quality of life that you want to have is definitely attainable.
It's not all doom and gloom, because that's where I was heading when I first. You're angry, and you're mad, and you're all of these emotions going on at the same time, and I think it's very natural.
You would be amazed at the inner strength that you have, that we all have in us. It's there in all of us.
My name is Cheryl Kraft.
I'm Wayne Brewer.
I'm Kathy Kurtz.
And currently I'm in heart failure.
I do it with heart failure.
And I am living with heart failure.
Perseverance. I just power through. It was definitely harder in the beginning because you're just adjusting to having children. And then there was a lot of fatigue, a lot of, I can't do this, I'm not gonna make it. We live in a 2-story home, so stairs still can be a challenge. I'm not supposed to carry the girls, much less upstairs, but Don't tell Dr. Park that I do. But I mean, I would do anything for my girls. So I do it with heart failure.
I think the biggest challenge that I have, well, there are a couple of challenges, but I think the biggest one is really getting individuals around me who don't know about my diagnosis to understand what heart failure is. And for them to be able to understand that not all heart disease is necessarily due to lifestyle factors. I think a lot of people assign a certain degree of responsibility to individuals, assuming that they do certain things and you have this certain outcome. And in many cases, that's true. But for me, I didn't have the traditional risk factors like diabetes, high blood pressure, etc., that would have led to that. So basically, it became the story that I had to tell of this disease that just sort of appeared, and being able to get people to understand that the need to still get themselves checked and be able to have important follow-ups at certain points, because it can pretty much happen to anyone. And so I think that was a big challenge. But then also from a more personal standpoint, I think just recognizing the fact that I have to sort of temper some of my goals a little bit from a physical fitness or athletic standpoint, to realize that now the training now is more about health and not training to compete anymore.
I don't live to the disease. I really don't. I live to what I want to do. And what my focus is to get me the best that I can do and do the best I can do and have fun while I'm doing it. And that's all I can do. I don't believe in the woe is me, and I don't want people feeling sorry for me. In fact, my team doesn't even know I have the level of heart failure that I do. And I keep it that way because people look at you a little like, oh, I feel sorry for you, because it's, overtly, it's not showing. I don't have an oxygen tank with me, and they're not seeing me do things during the middle of the day. So I'm sort of a different patient.
I try to remind myself that enjoy the day, enjoy it. Don't always look at all the negative stuff and get all upset about the little small stuff. Just try to do the best you can to enjoy yourself. And that's really what it boils down to. And I think that's something that really everybody should strive to do. I think we get caught in all the minutia, the negativity and stuff like that. There's a lot of great things happening all around you. You just got to look at it, change your mindset. And that's what it boils down to, just sort of change how I look at things. And don't get me wrong, it's still a struggle in some cases. But when things are not going the way you want to, you have to ask yourself, well, there has to be a reason behind it.
I know intellectually I'm a heart failure person. I know that. But I guess in my childlike mind, maybe, I feel energetic, I want to do things, I've been snorkeling, I travel, I still work full-time, I fly full-time basically. And so for me, and I know everybody is different, for me, I've been able to continue to do the things that I want to do.
You know, they say moms of toddlers are tired, and I'm thinking, you don't know tired until you have heart failure. Right now, I'm able to, I feel like for the most part, keep up with them. I worry about when they get older and more active, I won't be able to keep up with them, and that worries me. You know, just riding our bikes around the neighborhood or going for a hike. I worry that I won't be able to keep up.
I don't really see it as a challenge, except, and I think the team will tell you that when I do have the echo done every 3 months, and I have it, and I always have this trepidation about what those numbers are. But I've come to learn that the numbers aren't the end-all be-all. So if my ejection fraction was, say, 28 or 29 this time, and it jumps up to 40, and then it's back down to 33, personally, I was freaking when that happened, but when Dr. Trachtenberg explained it, it made it all better. So the challenge for me is to remain calm when I get those numbers, because the numbers aren't the end all be all. It's how you feel. It's on your day-to-day basis, what you're doing. you know, and I feel alive. I feel like everybody else without heart failure.
I think there's a resilience, and it was just, it took us this long to get here, and kind of not accepting no as an answer. And so that's where you start doing your research and you find look out for other opinions. That's how we ended up at Cleveland Clinic and then here at Methodist. So just refusing to give up and take it day by day.
My son had open heart surgery. You know, he had a congenital cardiac issue that required him to have open heart surgery 2 Christmases ago. So put all this in perspective for him. And so knowing that I have heart disease and knowing that he could have succumbed to something very similar, I think puts it in a unique light, because I talked to both him and my daughter about the need for them to get screened properly over time, because it could be more of a genetic issue. But in terms of how they perceive me and perceive, you know, daddy's own mortality, I have yet to have that conversation. I'm almost, in some ways, a bit uncomfortable, you know, having that with them. But on the flip side, I think there is a sense of assurement that I'm doing everything that I possibly can to stay here as long as I can.
I'm in awe over her strength. I truly am. The worst part for me was during the pregnancy, and she's supposed to wear this defibrillator vest. Well, she's pregnant. A pregnant woman needs her rest, and she can't get comfortable wearing it. So at night when she sleeps, she doesn't wear it. So each morning, I would wake up, whether it was to get ready for work or every morning, and I would look over at her and see if she was still alive. You would never know the difference. I mean, it's not like it, you know, I could be sleeping and she could pass in the middle of the night and I wouldn't know. And so every morning, that concern, that not knowing if she was still with me or not, that was the worst part. There were times of, you know, breakdown where you just wanted a normal pregnancy and why me, but you know, it was as a team. We fought this as a team, and we made it through. And we're still fighting as a team, fighting as a family. You know, certainly her attitude and perseverance, faith, absolutely, that was the most important thing. And I was on the sideline cheering her on, doing whatever I could, and just held on to that roller coaster. I find my strength in her strength. You know, again, it's that perseverance of, and thinking about others, thinking about her, putting her needs at the forefront, and because I need her around for a while, you know. So we need to make sure she takes care of herself, and that she's okay. You know, we got these 2 girls. They need their mom.
So when I was pregnant, he really had to step up, and he was amazing. Just helping me get dressed or shower. Never complained. Never left my side, and I mean that physically and emotionally. Like, he was so supportive when I told him that we were going to have these babies. He didn't try to talk me out of it. he jumped on board and took that leap of faith with me, and I'm so grateful for that.
And so I would just, I'd help her when needed, if whatever, and then I would just stay nearby so that if she needed anything else.
Slept every night with me in the hospital except when ICU, he wasn't allowed. And then even in, after delivery, he was gonna sleep in the waiting room.
During pregnancy, I can't remember how far along she was, but this one night she had just horrible indigestion, just worst I'd ever seen her have it. And so I'm thinking, okay, we need to put her on an incline. She can't sleep. I don't know, it's probably midnight or something. When she can't sleep, the pregnant woman with heart failure needs her sleep. And so I'm thinking, okay, we need to incline the bed. Well, how do you incline a king-size bed at midnight? Then I said, okay, let me figure this out. So I had some plywood and ended up stacking some pillows on the floor, laying the plywood at almost like a bike ramp on that. And then I think we had some other blankets or padding that I put on top of that, and then a sheet. And so it was like this, well, maybe like this, and on the floor. And in the middle of the night, you're just out there, MacGyver this thing together with whatever you have so that, she can try and get some rest.
So I slept on a bike ramp that night. I mean, most people would just throw you another pillow, and this guy built a bike ramp for me to sleep on.
Yeah, in our bedroom, off to the side of the bed.
So that's how dedicated he was to helping me.
I've accepted the diagnosis. I've accepted the changes that I've had to make, and luckily so far I'm in the early stages. So the lifestyle changes have been more so diet, so paying attention to salt intake, paying attention to excess fluid intake. Exercise-wise, I've sort of changed my goal with exercise. Before it was just to go out and just do as much as I can and just compete and do different things. Now it's more for enjoyment, it's for health, and it's for maintaining my ability to do the things that I really like to do.
I'm very, very diligent about following what the team wants me to do. You just monitor my weight because of fluid. I do that on a daily basis. And communicate with your team. The other thing is to really keep a good record of your blood pressure. Even if it's just writing it down, and blood pressure, the date and the time, because it helps them when you bring that log in to see exactly what's happening. And I also add notes to that say, okay, this is where I increase the medicine they told me to do, or this is where they told me to decrease or stop or whatever, so that they can see absolutely what's going on in your home, because it's very different when you show up and get your blood pressure here. I know mine goes up tremendously. So
I pay attention to my symptoms. If I feel a little fatigued certain days, I may refrain from doing excess activity and maybe plan them out, pace myself a little bit better. But in general, overall, I just try to live a very similar life as to what I had before.
We call this our new normal. I have heart failure. It doesn't seem to be going away. I just have to deal with it. As far as normal routine, before children, I worked, I commuted. I'm a stay-at-home mom now, and that's my new normal. So it's hard to separate the heart failure and the pregnancy because it basically happened at the same time. So I know my life would be different anyway because I have children now.
it's just part of my habit now. It's just what my blood pressure cuff and my notes are right there next to each other. I have a wrist cuff and I take it, and it's very, very, very doable, and it's really part of my routine. I take other medications anyway. I mean, when you're this age, you're taking, whatever, Premarin or something else. So it's just another part of the routine added in. I talk a lot to my fiance about it, and just once I have these, and it usually happens right before the test, that I have this kind of like, oh my God, what's it going to turn out to be? And it's the same thing with the checkups for cancer. I mean, oh my God, what's it going to turn out to be? And it's not like you're negative. It's just that that's a realistic part of what goes through your brain. And then once it's done, you're okay. So the resources here are wonderful, having the team, certainly having the medications and being flexible in those medications now. A lot more medications and things to manage heart failure than there were many years ago when my grandparents were in heart failure. And I think that's a lot of times what people remember. They remember years ago in heart failure. Heart failure is managed very differently now, and it is manageable.
Well, I think the key thing is really to have faith and perseverance with this disease. I know this is something I'm gonna live for the rest of my life with. It's chronic. I know there's gonna be some days that are better than others. And I think it's all about keeping things in perspective. And I think the people who are around me, my loved ones and friends, that they understand the perspective that I'm coming from. Every day on this earth is a gift for everyone. And so I realize that and cherish that even more so with this. And that's just pretty much the tenets that I live by right now. And I just really try to do the best I can to live the healthiest life that's possible.